respiratory physiology. And then the second one is for next week. We still have one more session of physiology. So, Dr. Solidum will give the review on GI and renal physiology next week. Okay, so we only have 2 weeks, so total of 8 hours. So some of the topics in physiology cannot be covered, like endocrine, cellular physiology. So we just focus on the four major organ systems. So cardio, respi, GI, and renal. Okay. So our review is actually a question and answer format. So we'll flash a question, and then you have their multiple choice question. Then you have four options. Then we will explain the concepts related to that question. Okay? So it's gonna be a quite long review. So talagang maximize natin yung 4 hours. But of course, you're free anytime if you want to eat, if you want to have snacks. But between the two topics, respi and then to be followed by the cardio, we'll have a 15-minute break so you can rest, no? And then we'll proceed with cardio. So more or less, we're gonna be done by around 12 or past a little bit past 12, probably up to 12:30. No? So you have to be patient, no? But you're gonna be reviewing all the concepts related to both cardio and respiratory physiology. Okay, so basic rules, of course, you have to mute your microphone, and then if you have any questions, we have the chat box. So dun nyo lang i-send, but you can send a message. I can read your questions, and then we'll discuss the questions after each topic. Okay? So do you have any questions right now with regards to the review? Sino nagre-record? Angie, are you here?
Sorry po. Try ko lang po.
You cannot record the review, sorry. Only the organizer can record. Sorry, Gaya. Si Angie ba? Wala dito. Angie is our secretary, di ba?
Dok, wala pa po.
Oo. So you cannot record the meeting, the review. We'll give you a copy, but do not record the review. Kasi ginagamit namin ito lagi, but we'll give you a copy once we're done with the review in physiology. Okay? So, any question? So, medyo mahaba lang talaga siya, ha? You have to be very patient. Pero, ano talaga, comprehensive review talaga siya. No questions? So, I'm gonna be sharing the screen. So, kung may question kayo again, dun lang po tayo. You just send a message to me, okay? So, let me just share the screen now. And then let me know sa chat box kung merong technical problem, like if you cannot hear or if you cannot see the video or see the PowerPoint presentation or hear the audio. You just send a message to me, okay? So, kung may technical issues tayo. Okay, we're gonna start now. Be ready. So, we'll start with respiratory physiology, okay?
Good morning. So we'll have the review on respiratory physiology, and then later to be followed by the review on cardiovascular physiology. So here's the first question. The affinity of hemoglobin for oxygen is increased by. So you have here four options. You have here the pH, the temperature, the partial pressure of carbon dioxide in the initiation of your oxygen from your hemoglobin. So before we answer this question at this point, we have to review the Bohr effect and Haldane effect in respiration. So what is Bohr effect? So Bohr effect is the effect of carbon dioxide on the affinity of hemoglobin for oxygen. So when your blood pH falls, primarily due to an increase in PCO2, this will decrease the affinity of oxygen to hemoglobin. Why? Because deoxyhemoglobin binds hydrogen and carbon dioxide more compared to your oxyhemoglobin. So in the tissues, so for example, when you have an increase in metabolic activity, this will result in an increase in waste product, particularly your carbon dioxide. So what will happen to your carbon dioxide? It will diffuse into the blood, and about 90% of this carbon dioxide will enter the RBC. So in the RBC, it will combine with water to form your carbonic acid in the presence, of course, of the enzyme carbonic anhydrase. So once you have the carbonic acid, it will dissociate spontaneously into your bicarbonate and hydrogen ions. So what will happen now? Your hydrogen ions now will bind with your hemoglobin. And when it binds to your hemoglobin, it will alter the conformation of your hemoglobin such that there will be decreased affinity now of your oxygen from hemoglobin. So this will lead to a rightward shift of the oxyhemoglobin dissociation curve, and this will now facilitate oxygen unloading in the tissues. So the oxygen unloaded now in the tissues will be used by the tissues. Okay. Now, what about the bicarbonate? So remember that in the RBC, your carbon dioxide will also result in the formation of bicarbonate from carbonic acid. So this bicarbonate will now diffuse out of the RBC. So since the bicarbonate moves out of the RBC, it will facilitate now, or it will cause the entry of chloride into your RBC. So this is what is known as the chloride shift, or the hamburger phenomenon, if you remember. So why is it that the chloride enters the RBC in exchange of for your bicarbonate? So mainly to maintain electrical neutrality. So bicarbonate exits out while your chloride enters the RBC. So again, this is the chloride shift to maintain electrical neutrality, or what is also known as the hamburger phenomenon. Okay. Now at this point, your venous PCO2 now rises. Okay. Now, in the lungs, so when it reaches the pulmonary circulation, so in the lungs, what will happen now? So the venous PCO2 is very high now. It's about 46 millimeter mercury, whereas the alveolar PCO2 is only about 40 millimeter mercury. So there is a pressure gradient now. So this will drive the carbon dioxide out of the pulmonary capillary into the alveoli. So as it exits now the capillary into the alveoli, what will happen now? You will have a decrease in the partial pressure of the carbon dioxide. Okay, so at this point, there will now be a leftward shift of the oxyhemoglobin dissociation curve. So this will now facilitate oxygen loading in the lungs. Okay, so in summary, in Bohr effect in the tissues, it will because of the increased metabolic activity, it will increase the waste product, your carbon dioxide, and this will cause a rightward shift. Not only the carbon dioxide but also the hydrogen ions. So you have a rightward shift of the oxyhemoglobin dissociation curve. So this will facilitate oxygen unloading. However, in the lungs, the carbon dioxide is exhaled because of the presence of the pressure gradient between the alveoli and the capillary. So at this point, there will be a leftward shift, and this will now facilitate oxygen loading. So that is Bohr effect. So what about Haldane effect? So let's go now to Haldane effect. So this time, Haldane effect is the effect of oxyhemoglobin saturation in the transport of carbon dioxide. So when you have the oxygenated hemoglobin, there's now increased capacity of that hemoglobin to carry your carbon dioxide. Again, why? Number one, deoxygenated hemoglobin binds hydrogen ions and carbon dioxide compared to oxyhemoglobin. Okay? So we go back now again in the tissues. So what will happen in the tissues? There is, because of the, remember, when you have oxygen unloading in the tissues, there will be a decrease in oxyhemoglobin saturation. So this will now facilitate carbon dioxide and hydrogen loading. Okay? What about in the lungs? So in the lungs, there will be oxygen loading. Again, why? Because of the pressure gradient that exists between the alveoli and the pulmonary capillary. So the PO2, alveolar PO2 is about 100, whereas the venous PO2 is about just 40. So this is a very big pressure gradient that will facilitate now oxygen to diffuse out from the alveoli into the pulmonary capillary. So at the end of the pulmonary capillary, you have now an increased oxyhemoglobin saturation. And because of this increased oxyhemoglobin saturation, there will now be unloading, further unloading of the carbon dioxide and hydrogen. Okay? So in summary, so in the tissues, an increase in metabolic activity will increase the PCO2 and therefore decrease the pH level. And this will facilitate oxygen unloading. So this is the Bohr effect. Now, oxygen unloading will decrease oxyhemoglobin saturation, which will further facilitate now loading of carbon dioxide into the blood. So this is the Haldane effect. So what about in the lungs? Again, primarily because of the pressure differences between the alveoli and the pulmonary capillary, there will be movement of the gases. So when you have the venous PCO2 now is increased. It will facilitate carbon dioxide exhalation. So this will decrease the PCO2 level and increasing the pH. So at this point, you have oxygen loading. So this is again the Bohr effect. Now, when you have diffusion of oxygen this time from the alveoli into the pulmonary capillary, it will increase the oxyhemoglobin saturation. So this will further facilitate unloading of carbon dioxide into the alveoli. Again, this is the Haldane effect. So this table shows again the different factors that will decrease the affinity of hemoglobin for oxygen. So as what we have said earlier, when you have increased PCO2 and you have increased hydrogen ion concentration, this will decrease the affinity of hemoglobin for oxygen. So shifting the dissociation, oxyhemoglobin dissociation curve to the right. Okay. Now, an increase in the metabolic activity will also increase the generation of heat in the cells, in the tissues. So this will increase the core temperature in the body. So this will, again, cause a rightward shift of the oxyhemoglobin dissociation curve. So what about 2,3-DPG? So 2,3-DPG is actually a metabolic intermediate in glycolysis. So if you remember, RBC, they do not have mitochondria. So they rely on glycolysis as a source of energy. So an increase in the 2,3-DPG, it actually directly, this 2,3-DPG directly competes with your oxygen for hemoglobin. So an increase in the 2,3-DPG will now cause decreased affinity of hemoglobin for oxygen. So this is the oxyhemoglobin dissociation curve, okay? So here you have the partial pressure of oxygen, and here you have the percent hemoglobin saturation, okay? Now, at 60 millimeter mercury, you can see that the hemoglobin saturation is already 90%. So meaning as you increase the partial pressure of oxygen up to 60 millimeter mercury, there will be an increase in the hemoglobin saturation. And again, at 60, you have already 90% saturation. But as you can see, this curve is actually not linear, no? So it's sigmoidal in shape. So from 60, it will now start to plateau. So as you can see here, so actually about 50, it already start to plateau. Okay, and at 70, you have actually already flattening. It was you have flattening of the curve now. Okay, so that's why it's sigmoidal in shape. Okay, so what does this mean? So between 60 to 100, there is very minimal change in the saturation of hemoglobin. So actually, there will only be a slight increase of about 70% from 60 to 100 millimeter mercury. Okay, so is this important? So actually, this portion, the flat portion of the curve, is clinically important. So why? So when your when your partial pressure of oxygen decreases from 100 to 60 millimeter mercury, the hemoglobin saturation is still 90, around 90%. So meaning, even if you decrease the partial pressure of oxygen, there is still adequate oxygen transport and delivery into the tissues. Okay, so the oxygen can still be delivered and can still be used by the tissues. So the problem is when you have now a partial pressure below 60 millimeter mercury, so it will now fall in this step portion. So here, the decrease in the hemoglobin saturation can now be clearly seen. So it will be larger now compared to the flat portion of the curve. So this will now, at this point now, this will compromise the oxygen transport and delivery into the tissues, and this will lead to the deterioration of the patient eventually, which may lead to the untimely demise of a patient if you do not correct this hemoglobin saturation. Okay, so going back to the question now. So the affinity of hemoglobin for oxygen is increased by, so you have here the four factors affecting the dissociation of oxygen from hemoglobin. So here you have the pH, the temperature, the PCO2, and the 2,3-DPG levels. So we already know that there will be decreased affinity of oxygen if there is a rightward shift. Okay, but here the question is actually affinity of hemoglobin for oxygen is increased. So meaning leftward shift. So what are the factors that will lead to a leftward shift of the oxyhemoglobin dissociation curve? Okay, so we're quite sure that an increase in the PCO2 level and an increase in the 2,3-DPG level will cause a rightward shift. Okay, so this will cause the dissociation of oxygen from your hemoglobin. What about A and B options? So warming the blood, increased temperature will also cause a rightward shift. So the option left will be raising the pH. So meaning an increase in the pH, meaning you have a decrease in hydrogen ion concentration. So when you decrease the hydrogen ion concentration, there is actually a leftward shift. So in this case, the correct answer is letter A. So we go to the next question. The central chemoreceptors respond with increased output too. So here you have four options. So these are mainly stimuli that will increase the activity of the chemoreceptors. Okay. So let us now discuss the two types of chemoreceptors. So the first type of chemoreceptors are your peripheral chemoreceptors. So the peripheral chemoreceptors are found in the, here you have the carotid body. So this is in the bifurcation of the common carotid. And here you have the aortic body. So it's found in the arch of aorta. Okay. So what will be the stimuli for firing of this chemoreceptors, peripheral chemoreceptors? So whenever you have a decrease in your PO2 levels, an increase in pH, a decrease in pH. So meaning there is an increase in the hydrogen ion concentration. And lastly, an increase in PCO2. Okay. So when you have these conditions, it will stimulate the activity, or it will increase the activity of the carotid body and the aortic bodies. So in the carotid body, it will send the signals into your respiratory center via the glossopharyngeal nerve, whereas in the aortic bodies, it will send the signals to the respiratory center via your vagus nerve. So this is the first type of chemoreceptors. So the second one would be your central chemoreceptors. So your central chemoreceptors are found in the ventrolateral portion of the medulla near the exit of cranial nerves 9 and 10. So here you have cranial nerve 9, cranial nerve 10, and this will be your central chemoreceptors. Okay, so the central chemoreceptors mainly respond to an increase in PCO2 level. Okay, so here this is the table that will show you the major stimuli for both the peripheral and central chemoreceptors. So as I said earlier, a decrease in the PO2 level and an increase in hydrogen ion concentration or a decrease in pH will now stimulate the carotid bodies and the aortic bodies, sending now signals to your respiratory center. Whereas central chemoreceptors will respond mainly to changes or to an increase in the PCO2 level. So actually, an increase in PCO2 will both stimulate your peripheral and central, but it is the major stimulus for firing of the central chemoreceptors. Okay. Now, but if you look at this one, it is the chemoreceptors, central chemoreceptors are stimulated by increased PCO2 via associated changes in hydrogen ion concentration. Okay, now it is only carbon dioxide that can actually cross the blood-brain barrier. Okay, now however, it does not directly stimulate the central chemoreceptors. So it is actually the hydrogen ion that will directly stimulate the central chemoreceptors. So where will the hydrogen ion come from? Okay, so as what we have said, it is only the CO2 that will now can cross the blood-brain barrier. So here's the figure showing this one. So here you have the carbon dioxide that will diffuse out into the CSF. So in the CSF, it will combine with water to form your to form your carbonic acid via the activity of enzyme carbonic anhydrase. So this will dissociate now into bicarbonate and hydrogen ions. So as you can see here, these hydrogen ions formed from this reaction and actually derived from carbon dioxide will be the one that will directly stimulate the central chemoreceptors. Okay, so even though the CO2 is the one that crosses the blood-brain barrier, eventually it is the hydrogen ions that will directly stimulate the central chemoreceptors. So here in summary, so you have the peripheral chemoreceptors. So in the arterial blood, a decrease in the PO2 level. So you have here a decrease in PO2 level, less than 60, as I've said earlier, less than 60 millimeter mercury, and an increase in the PCO2 level, as well as an increase in the hydrogen ion concentration, which will decrease your pH, will stimulate your peripheral chemoreceptors. So as you can see, the hydrogen here is derived from your carbon dioxide. Now, as I've said earlier, your major stimulus for central chemoreceptors is mainly an increase in the CO2 because this is the one that will cross the blood-brain barrier, and the hydrogen derived from your carbon dioxide will be the one that stimulate your central chemoreceptors. Okay, so both both of these receptors will now send signals to your respiratory control center and will increase now your ventilation. So meaning increased activity of these receptors will increase the ventilation. So going back to the question now, the central chemoreceptors respond with increased output too. So meaning uh, there will be increased signals that will be sent to the respiratory center. Okay, so since it is the central chemoreceptor, so meaning the stimulus will actually be your carbon dioxide. Okay, now if you look at the first option, it's actually an increase in blood hydrogen ion concentration. So this is arterial blood and will actually stimulate your peripheral chemoreceptors. So what about option B? So option B, it's bicarbonate. So bicarbonate is not a stimulus for firing of your chemoreceptors. Okay. So letter C, decrease arterial blood PCO2. So again, this is arterial blood. So meaning it will actually stimulate the peripheral chemoreceptors and not the central chemoreceptors unless it crosses the blood-brain barrier. So you have now an increase in CSF hydrogen ion concentration. So as the carbon dioxide crosses the blood-brain barrier, then it will form carbonic acid, which will dissociate into your hydrogen and bicarbonate. So it is now the hydrogen in the CSF that will stimulate your central chemoreceptors. So therefore, the correct answer here is letter D. An increase in the CSF hydrogen ion concentration will stimulate the central chemoreceptors. Okay? So here's the next question. Let's move on to the next question. The total quantity of air that can be expelled from the lung after a maximal inspiration is known as that. So you have here the different volume and capacities in the lung. So we now review the different volumes and lung capacity. So we go to the next slide. So here's a figure showing you the different lung volumes and capacities. So capacity is actually is just composed of two or more volumes. Okay. Now here you have here the tidal volume. So this is the volume of air that is moved in and out with each breath. So on the average, it's about 500 ml. And this one is the inspiratory reserve volume. So this is the additional amount of air that can be forcibly inhaled after a normal tidal volume. Okay. Now, what about residual volume? So residual volume is the amount of air that remains in the lungs after forceful expiration. Okay. So this cannot be actually measured, your residual volume. So ERV, on the other hand, would be the amount of air that can be exhaled after a forceful expiration. Okay. Now, inspiratory capacity is, of course, the combination of IRV and the tidal volume. FRC is you have the ERV plus the residual volume. Okay, now vital capacity is actually total lung capacity minus the residual volume. And of course, you have the total lung capacity is the sum of all this one. The IRV, ERV, the TV, and the residual volume. So actually, you might have a question here. You may be wondering, why is it that there is always a residual volume in the lungs? So this residual volume will actually keep the alveoli open. Okay, but why is it that even after a forceful exhalation, you still have remaining volume in the lungs? Okay, now during forceful exhalation, you have the contraction of the expiratory muscles. But at the same time, as the expiratory muscles contract, the recoil pressure of the chest wall likewise increases. Okay? Now, at a certain point, the force generated by the expiratory muscles cannot overcome the outward recoil of your chest wall. So this now determines your residual volume. So even after maximum or forceful exhalation, you can never squeeze all the air out of your lungs, mainly again because of the recoil pressure of the chest wall. So if we go back to the question now, the total quantity of air that can be expelled from the lung after a maximal inspiration. So what will this be? So you have maximal inspiration. So it's not only the tidal volume, but also your your inspiratory reserve volume. So the IRV and your tidal volume will be your inspiratory capacity. But here it says here the total quantity of air that can be expelled from the lung after a maximal inspiration. And so this will likewise include now your expiratory reserve volume. So meaning after maximal inspiration, you also expire forcefully. So you can expel all the air from your lungs. Of course, excluding the reserve volume. So this will now constitute your IRV, your tidal volume, and your ERV. So what will be the correct answer here now? So the sum of all these three will be your vital capacity. Okay, so vital capacity will be the sum of all three, whereas the functional residual capacity, it's actually just the sum of your ERV and your residual volume. So that since it's inspiration, maximal inspiration, and so this will be your sum of your ERV, IRV, and your tidal volume. So you have here the correct answer, vital capacity. So here's the next question. So here, perfusion without ventilation. So you have here the different choices. Okay. So at this point, we will now discuss ventilation perfusion ratio. Okay. So I think you're already familiar with the term VQ ratio. So we will now discuss this VQ ratio. So when do you say VQ is below normal? So when there is no ventilation, but there is positive perfusion. So the ratio now will be below normal, okay? So in this case, there is no gas exchange that will take place because there is no air in the alveoli. So the blood now continues to be mixed venous blood as it is transported from the right to the left side of the circulation. So this is what you call now physiologic right-left shunt, okay? So in this case, the blood is said to be wasted because it cannot pick up the oxygen because there is no oxygen. Okay. What about when do you say VQ is above normal? So this time you have air in the alveoli, so there's ventilation, but there is no perfusion. So again, because there's no perfusion this time, no gas exchange takes place as well. So the air remains in the alveoli. So you have physiologic dead space, and in this case, the air is said to be wasted. Okay, so again, when the VQ is less than 1, you have physiologic right to left shunt. On the other hand, when the VQ is above 1, then you have physiologic dead space. So here you have the lungs. So actually the lungs is divided into several zones. Okay. Now since you have different zones, so there will actually be areas with normal VQ, and there will be areas with below normal or above normal VQ. Okay, so let us now review the different zones in the lung. So in zone 1, so here you have the zone 1, it's usually found in the apex. Okay, so here you have a very high alveolar pressure, greater than your arterial and venous pressure. So in this case, you have a very high alveolar pressure. It will actually compress the capillaries. Okay, so what will happen now? When you have compression of the capillaries, there will be less perfusion. So in this case, in zone 1, the VQ, you have greater ventilation more than your perfusion. So you have a very high VQ. So in this case, you actually create a dead space. Okay. Now in zone 2, so if you look here in zone 2, this time the arterial pressure is greater than the alveolar pressure. Okay, but the alveolar pressure is still greater than the venous pressure. So as you can see here, towards the venous end, your alveolar pressure is higher, so it will compress the venous end. But here you have greater arterial pressure, so at this point, there's already exchange of the gas because the arterial pressure is greater than the alveolar pressure. So there will be adequate exchange of the gas. So even if the alveolar pressure is greater than the venous pressure, since you already have gas exchange that takes place in this part of the capillary, then at this in this particular zone, more or less, you have a normal VQ. The next one is, of course, your zone 3. So in zone 3, as you can see here, um, both your arterial and venous pressure now is greater than the alveolar pressure. Okay, so in this case, there is perfusion, but since the alveolar pressure is low, there is actually lower ventilation or no ventilation at all that can take place. Okay, so what will happen since you have greater arterial and venous pressure, there will no gas exchange that or very minimal gas exchange that will take place. So therefore, your VQ now will be below normal. And in this case, since there is no gas exchange that will take place. So the blood now will be that of the mixed venous start. So you have now a right to left shunt. So in this case, you have your wasted blood in this case because it is not adequately oxygenated. There's actually another zone, which is zone 4. Zone 4 occurs at the very base. So it occurs at the very base of the lung. Okay. So in zone 4, this time it's actually the interstitial pressure that is high. Okay, higher than the alveolar or the venous pressure. So in this case, in zone 4, the arterial pressure is greater than the interstitial pressure, but the interstitial pressure is greater than the alveolar pressure and the pulmonary venous pressure. Okay, now why is this so? So in this case, at low, this may occur when you have let's say pulmonary edema or at very low lung volumes. Okay, so its effect is actually not really it's actually negligible because it's mainly in the base very base of the lung. So the blood flow is reduced in this area because the vessels are actually compressed by the interstitial pressure. So that's why the alveolar pressure remains low and the pulmonary venous pressure also is lesser compared to your interstitial pressure. Okay, so but again, this is at the very base of the lung. So even if you have a lower VQ in this case, or it will still be negligible. Okay. Now, they also say that zone one, actually, this condition is generally said to be absent in the normal lung under physiologic conditions. So normally you do not have really a very high VQ in the apex. However, zone 1, you have higher ventilation here, may be present under two conditions. So the first one, when the pulmonary artery pressure is really very low. Okay, so normally the pulmonary pressure is still high coming from the right side of the uh, from the right side of the heart, from the right ventricle. Your pulmonary artery pressure is high. Okay, now that's why zone 1 does not really exist. However, when your pulmonary artery pressure is low, such as for example when you have hypovolemic shock, then you will create a dead space. So there will be a very low perfusion because of the reduced pulmonary artery pressure. Okay. Now, also in cases when you have very high ventilation or increased ventilation during positive pressure ventilation. So in this case, in positive pressure ventilation, the alveolar pressure is really very high. So this will, of course, again, when it's very high, it will create dead space. So again, under normal physiologic conditions, zone 1 is absent. So it may be present when you have a very high pulmonary artery pressure, such as, when you have a very low pulmonary artery pressure, such as when in cases of hypovolemic shock, or when you have positive pressure ventilation, which will increase greatly your alveolar pressure. So again, these are the different zones in the lung. So we go now to the question. We go back to the question. So perfusion without ventilation. So you have here the following options. So it acts like an AV shunt, an increase in dead space, increase in oxygen in alveoli, or an increase in partial pressure of oxygen in alveoli. So when you say perfusion without ventilation, there's actually a right to left shunt. Okay, so meaning if you look at option C, without ventilation, so here it shows here increase in oxygen in alveoli. So this is incorrect. Okay. Letter D, increase in partial pressure of oxygen in alveoli. Again, this is incorrect because as from the STEM question, it says here without ventilation. So C and D, both incorrect. So you only have two options left. So first one is it acts like an AV shunt, and second one, it acts like an increase in dead space. Okay. So when you say dead space, meaning there's air in the alveoli, wasted air in the alveoli. But again, going back to the question, it says here without ventilation. Okay. So the correct answer here, of course, would be letter A. So it acts like an AV shunt. So meaning the blood now will remain unoxygenated as it passes the alveoli. So from the right side of the heart to the left side of the heart, it remains unoxygenated. So this the correct answer here is that perfusion without ventilation acts like an arteriovenous shunt. So here's the next question. Which of the following has the highest airway resistance? So you have here the four choices. So these are all actually part of the lower respiratory tract. So the lower respiratory tract actually starts from the trachea down to the terminal bronchioles. Okay, so the trachea will divide into the left and left and right main bronchi, and from there it will further divide in a dichotomous branching pattern. So there are about, on the average, 23 generations from trachea down to the terminal bronchioles. So here in this figure, you can see the airway generation from the trachea down to the alveoli. Okay, so the conducting zone actually starts from the trachea down to the smallest bronchiole, and the respiratory zone starts from the terminal bronchiole down to the alveoli. So in this figure, it also shows you the resistance, the airway resistance. So as you can see, the airway resistance is actually maximal in this area. So this is about 4 to 8 generations from the trachea, 4 to 8 generations of airway. Okay, so in this figure, it will show you again the airway resistance, which is maximal in this area. again, about 4 to 8 airway generation. So this 4 to 8 airway generation is actually found in your medium-sized bronchi. Okay, so here in this particular area. So not in the main bronchi, but in the medium size. So why? So both in the trachea and in the large bronchi, your main bronchi, the diameter of the airway is of course greater than that of the medium-sized bronchi. So there will now be greater airflow. So we already know that when you have increased diameter of the airway, so just like in your blood vessel, there will be lower resistance or decreased resistance. So if the resistance is decreased, then you have a greater airflow. As compared to your medium-sized bronchi, so this time you have mid-size of the mid-size diameter. So this will now increase the resistance, or you have now greater resistance compared to your larger trachea and the larger bronchi. So the increase in resistance now will decrease the airflow. So you have now a much slower airflow in the medium-sized bronchi. So therefore, the region of maximum resistance will be found in this area, in the medium-sized bronchi. Now, as you go along the bronchioles, so as you can see now, the resistance is actually decreasing. So at this point, when it reaches the terminal bronchioles, you have very low resistance. So why? You have two main reasons. So first, you have greater cross-sectional area. And second, the branches now will be in parallel. So when you have a parallel branching of the airways, there will be the total resistance will actually be reduced. So compared to when the branches will be in series. So if you remember in hemodynamics in your lecture in cardiovascular physio, when the vessels are in parallel, the total resistance will be reduced because it will be the sum of the reciprocal of all the individual resistances. Whereas when the vessels are in series, the total resistance will be the equal to the sum of resistance of each of the vessel. So same thing in the bronchioles. So in the bronchioles, the branches will now be in parallel. So therefore, the total resistance now will be reciprocal of the sum of the reciprocal of the individual resistances. So the total resistances now will be reduced. Okay, so this will decrease the total. This will now lead to a greater airflow. Okay, again, aside from that, you have a greater cross-sectional area, which will likewise increase the airflow. So you can see here that the resistance as you go along, as you go down the bronchioles, it is reduced. Gradually, it will be decreasing because again, primarily because of the branching of the airways. Okay, so parallel branches, you will have lower resistance. So if we go back to the question, which of the following has the highest airway resistance? So we have already answered this. Trachea having a very large diameter will permit lower resistance, therefore greater airflow. Terminal bronchioles, likewise, you have the branches in parallel, you have lower resistance. So largest bronchi, of course, when you have a large bronchi, again, greater diameter, lower resistance. So therefore, the maximum resistance, the region of maximum resistance to airflow is actually in your letter B, medium-sized bronchi. So we proceed to the next question. So here, during breathing, this pressure ultimately determines whether air flows in or out of the lungs. Okay, so you have here the different pressures in the lung. You have your alveolar pressure, your transpulmonary pressure, your pleural pressure, and of course you have your atmospheric pressure. Okay, so what is transpulmonary pressure? So this is also what is known as the trans-lung pressure or the transmural pressure of the lung. So it is actually the pressure distending the lung. So as you can see here, it is actually the difference between the alveolar pressure and the pleural pressure. So you have here the alveolar pressure and you have here the pleural pressure. Okay, so this is now your trans-lung pressure or your transpulmonary pressure, which will be the pressure that will try to expand or distend the alveoli. So the transpulmonary pressure is always positive. Okay. Now the pleural pressure is always negative. What about the alveolar pressure? So the alveolar pressure will move from slightly positive or zero to slightly negative during inspiration. Okay. So when there is no airflow, okay, the alveolar pressure is zero. Okay, so usually at the beginning of inspiration, the alveolar pressure is zero. So in this case, the pleural pressure and the transpulmonary pressure will have the same value, although with opposite signs. So remember, this is negative, always negative. So let's say the pleural pressure is negative 5. So your transpulmonary pressure is positive 5. Okay. Now, when you're during inspiration, your pleural pressure will become more negative. Okay. So, more negative pleural pressure will result in an increase in transpulmonary pressure. So why? So this is a negative sign. So if your pleural pressure is also negative, so actually it will now become positive. So negative, negative, you will have positive. Then you add that to the alveolar pressure. So your transpulmonary pressure will now increase. Okay. So to further explain this, let's go to the next figure. So here's the figure showing the changes in the uh, pressure and volume during inspiration and expiration. Okay. Now, during inspiration, signals coming from the respiratory center will cause contraction of the diaphragm. And this will also lead to expansion of the chest. So you have the contraction of the muscles of inspiration. So this will lead to a more negative intrapleural pressure now. So as you can see here, at the beginning of inspiration, you have here about negative 5 pleural pressure. But as you, when you start the inspiration, the cycle of inspiration, you will have now a more negative pleural pressure. So as you can see here, it will go down now, okay? What will happen now? So as I've said earlier, when you have a decrease in the pleural pressure, there will be an increase in the transpulmonary pressure. So negative, negative, so it will plus the alveolar pressure. Then you have now an increase in the transpulmonary pressure. Okay. So at the beginning of inspiration, some of the alveoli are closed, but with an increase in the transpulmonary pressure, this will now open up the alveoli and the alveoli will actually expand. So as you can see here, there will now be also an increase in the lung volume. So an increase in lung volume due to the recruitment of the alveoli. So this will further now, so an increase in volume will now cause a decrease in the negative alveolar pressure. So from zero, your alveolar pressure will actually now become more negative. So as you increase the transpulmonary pressure, you increase the volume, you now expand the alveoli. So the alveolar pressure now will become more negative. Okay? So when the alveolar pressure now is negative, what will happen? So there is a pressure gradient now from the between the alveoli and the atmosphere. So the atmospheric pressure is zero, whereas the alveolar pressure is negative. So this will cause the air to flow from the atmosphere into your respiratory tract down into your alveoli. Okay, so this will only stop when the alveolar pressure now is equal to your atmospheric pressure. Okay, now you also, however, you have to take note as you increase the transpulmonary pressure, there's also a corresponding increase in the elastic recoil pressure. Okay, so as you expand the alveoli with the increase in the transpulmonary pressure, making the alveolar pressure more negative because of the expansion of the alveoli, your elastic recoil pressure will likewise increase. So if you distend the alveoli, there will be also a corresponding increase in the elastic recoil pressure. Okay, so let me go to the next slide to better understand the elastic recoil pressure. So again, this is the transpulmonary pressure. It's the pressure distending the lung. So it's this one. Now, as you increase the transpulmonary pressure, you also increase the elastic recoil pressure. So as you distend the alveoli, because of the increase in the transpulmonary pressure, you also increase the elastic recoil pressure that will try to collapse the alveoli. So this is actually protective because you avoid overinflation of the alveoli. Okay, so going back to the equation, so your alveolar pressure is actually the sum of your elastic recoil pressure and the pleural pressure. So just by looking at this equation, you can actually already cancel the pleural pressure. So what's remaining now? You have your elastic recoil pressure. So your transpulmonary pressure is equal to elastic recoil pressure. So meaning, as you distend the alveoli with air, you also cause the collapse of the alveoli to prevent overinflation. So this should always be equal. Now, there are conditions or there are cases wherein you have changes in this transpulmonary pressure or elastic recoil pressure. So for example, if your transpulmonary pressure becomes zero, so for example, in cases of pneumothorax, your transpulmonary pressure now will be equal to that of your atmospheric pressure. Okay, so you have pneumothorax, so your transpulmonary pressure now will be equal to zero. So what will happen now? Because the transpulmonary pressure is very low, there will now be collapse of the alveoli. So the lungs now will collapse because of the automatic elastic recoil. Okay. Now, what about changes in the elastic recoil? So, for example, in emphysema. So, in emphysema, you have a decrease in the elastic recoil pressure because of the loss of elastin in the alveoli. So, this will decrease the elastic recoil pressure. So, when you decrease the elastic recoil pressure, what will happen now? You have an increased transpulmonary pressure that will cause now an increase in the lung volume. So, therefore, you have enlargement of the air spaces because you do not have the elastic recoil. Instead, what you have is an increase in the transpulmonary pressure that will enlarge now the alveoli. It will distend the lung. So you have now larger air spaces. So this is again a condition called emphysema, which is part of the, which is also part, a type of chronic obstructive pulmonary disease. Okay, so changes in both the transpulmonary pressure and elastic recoil pressure will cause either collapse in the lung or an enlargement of the air spaces in the lung. Okay. So going back now to the question, so during breathing, this pressure ultimately determines whether the air will flow in or out of the lungs. Okay, so if you look at the first choice, atmospheric pressure, so this is already out, no? So it really does not determine the inflow and the outflow of the air into your lungs. Okay, so this is incorrect. So what about the pleural pressure? So does this determine the flow of air. It contributes to the flow of air. Same thing with your alveolar pressure, it will contribute to the flow of air in and out of the lungs. Okay. However, the correct answer here, or the best answer here, is actually your transpulmonary pressure. Okay, so the transpulmonary pressure, as what we have said earlier, is determined by the difference between the alveolar pressure and the pleural pressure. So it will, what will happen when you have changes in the transpulmonary pressure? So this will determine the pressure in the alveoli that will now determine whether the air will flow in or out of the lungs. So as I've said earlier, when during inspiration, your alveolar pressure actually becomes more negative because of the expansion of the alveoli brought about by the increase in the transpulmonary pressure. Okay. Now, during what about during expiration? It becomes slightly more positive now. So this time the direction. So in inspiration, it's negative. So the direction of air is that from the atmosphere, the air will move down into the alveoli. Now, during expiration, the transpulmonary pressure now will be decreased. So this time, the alveolar pressure will become more positive. So this time, the direction of airflow will be from the alveoli out to the atmosphere. Okay, so that is during expiration. So during inspiration, you have a negative alveolar pressure that will move the air from the atmosphere into the alveoli. And during expiration, the alveolar pressure now is more positive. So the direction now will be opposite from the alveoli into the atmosphere. So the correct answer here would be letter C. Okay, so it will determine whether air will flow in or out of the lungs because the transpulmonary pressure will cause a change in the alveolar pressure. That will cause now the movement of air. Okay, so this is the next question. The ventilatory pattern that would result if the brainstem were transected at the caudal end of the medulla. So you have here the breathing patterns starting with apnea. Then you have the different types of breathing. So let us now discuss the respiratory center. So this is the organization of the respiratory center. You actually have several group of neurons, both in the medulla and in the pons. The dorsal respiratory group of neurons here is found in the dorsal portion of the medulla and contains mostly inspiratory neurons. So these cells are primarily responsible for inspiration. So it will send signals to the muscles of respiration. However, take note that this group of neurons does not send instantaneous burst of action potentials to your muscles of respiration. So rather, the signal will begin weakly and will steadily increase in a ramp manner. Okay, so that's why you call it this inspiratory signal a ramp signal because it will start weakly, then gradually increasing in a ramp manner. So again, it's called a ramp signal. Okay. Now the next group of neurons is found in the ventral lateral part of the medulla. So these are the VRG, ventral respiratory group of neurons. Now they contain both inspiratory and expiratory neurons. Okay. However, this VRG group of neurons will only function whenever there is an increase in the demand for ventilation. So it mainly supplies the accessory muscles of inspiration. So again, it will only function when there is an increased ventilation demand. Okay. Now, the third group of neurons would be your apneustic center. So it's actually found in your lower pons. Okay, so your apneustic center will actually send signals to both your DRG and VRG. So it will actually prevent switching off of DRG and VRG. So meaning it's preventing switching off. So there will be continuous inspiration, and the apneustic center actually limits exhalation. Okay, so but is that possible that you just inspire without exhalation? Of course not. Okay, so that's not compatible with life. Okay, so that's why you have this group of neurons in the upper font. So this is the pneumotaxic center. So the pneumotaxic center now sends inhibitory signals to the apneustic center. So meaning it will inhibit the activity of the apneustic center. So when there is inhibitory signals now coming from the pneumotaxic center, there will now be less signals coming from the apneustic center. So at this point, since there will be fewer signals coming from the apneustic center, there will now be switching off. Okay, so switching off of the DRG and VRG firing. So therefore, there will now be exhalation. Okay, so again, apneustic center will inhibit exhalation. So it will continuously send signals to DRG and VRG to prevent the switching off. But in the presence of the pneumotaxic center, it will inhibit the activity of the apneustic center. Therefore, there will now be switching off of the DRG and VRG firing. Okay, so there will now be exhalation or expiration. Okay. Now, so this is one way of controlling the respiration in the presence of the pneumotaxic center. Now, what about in the lungs? So actually, in the lungs, you also have control of respiration because you have there the presence of the stretch receptors. So the stretch receptors are located in the bronchial or bronchiolar walls, the walls of the bronchioles and the bronchi. Okay. So when the lungs are overly inflated, so continuous inspiration, okay, so remember you have signals coming from the apneustic, which will prevent the switching off of the DRG. So the DRG will continuously send inspiratory signals, right? So this will cause now inflation of the lungs. And when the lungs are overly inflated, the signals now, so it will stimulate now the stretch receptors found in the walls of the bronchioles. So this stretch receptors now will send signals to the respiratory center, and these are inhibitory signals to switch off the inspiratory signals in the DRG and the apneustic center. So it acts like your pneumotaxic center, so it will send inhibitory signals to both the apneustic center and DRG group of neurons. So you have now switching off of the signals coming from DRG. So this is what you call the Herring-Brewer inflation reflex. Okay, so Herring-Brewer inflation reflex in the presence of the stimulation of the stretch receptors by overinflation of the lung. Inhibitory signals will be sent to DRG and apneustic center to switch off the inspiratory signal. Okay? So, going back to the question here. So here, what will be the ventilatory pattern when you transect the brainstem at the caudal end? Okay? So you have here the four choices. So if you transect the caudal end of the medulla, what will happen? There will be no signals at all. No inspiratory signals will be sent to your muscles of inspiration. Same thing, there will be no signals for expiration in your coming from your VRG. So there will be no contraction of both the inspiratory and the expiratory muscles. So in this case here, you have the choices, but since there are no signals, so there will be no inspiration, no expiration. So the correct answer here would be letter A, apnea. Okay, so again, this is transection at the caudal end of the medulla. So no inspiratory signals, no expiratory signals. So the correct answer here would be letter A. So here's the next question. So the change in intrathoracic volume during quiet respiration is primarily due to which of the following respiratory muscles? Okay, so let us now review the muscles of inspiration and muscles of expiration. Inspiration is actually an active process that occurs when the chest cavity expands because of the contraction of the muscles. Okay, so what the diaphragm is actually the major muscle of respiration. So when the diaphragm contracts, it will move down. Okay, it will be moved down and pushes the contents of the abdominal cavity downward. Okay. Now, the other inspiratory muscles would be your external intercostals. So, in the case of external intercostals, so it will actually pull the ribs upward and outward. So, in this case, it will expand the chest cavity. Okay. Now, you also have accessory muscles of inspiration. So the sternocleidomastoids and the ischions. So both muscles will also likewise pull the ribs upward. Okay. So what about expiration? So expiration is a passive process. So it mainly relies on elastic recoil of the stretched lungs as the inspiratory muscles relax. Okay. Now, however, this expiration can actually become an active process, particularly during exercise and hyperventilation. Okay, so you also have the muscles of expiration here. So you have here the rectus and the transversus abdominis, the internal oblique and the external oblique, and lastly your internal intercostal. So your internal intercostals this time will pull the rib downward. So the effect is opposite to that of the external intercostals. Okay. So during inspiration, you have actually expansion of the chest cavity and chest cavity. So movement of the rib cage outward, as also the movement of the diaphragm downwards will enlarge the uh, chest cavity. And of course, during expiration, there will be elastic recoil, not only the lungs, but also the chest wall. There will also be elastic recoil of the chest wall. Okay, so those are the muscles of inspiration and muscles of expiration. So we go to the question now. The change in intrathoracic volume during quiet respiration is primarily due to which respiratory muscle? So again, it's mainly the major muscle of respiration. So the correct answer here will be letter A, diaphragm. Okay? So we move on now to the next question. So here the pulmonary circulation is. So you have here 4 options that will describe the pulmonary circulation. So let us now review pulmonary circulation. Okay, so moving on to the next slide. I think you're very familiar with Ohm's law. So Ohm's law states that the flow is equal to the pressure difference and it's inversely related to the resistance. Okay, so this is Ohm's law. Flow is equal to pressure difference or the pressure change from one end to the other end over resistance. Okay, so if we rearrange the equation, so this time you have here the resistance. So it's inversely related to flow and directly related to the pressure difference. Okay, so here we can apply this Ohm's law in the systemic circulation. So here you have here the resistance in the blood vessel. So you have systemic vascular resistance. So this will be equal to the pressure from the left side to the right side. So that's the systemic circulation starting from the aorta. So you have here the pressure in the aorta, and the end of the gradient would be in the right atrium. Okay, so the flow now will be determined. The flow in the circulation will be determined by your cardiac output. So normally the pressure in the right atrium is 0, correct? So the pressure actually will be mainly determined in the arterial system. So here, let's go to the this one equation. So the total peripheral resistance, so it's the same as your systemic vascular resistance. So as I've said, since the pressure in the right atrium is 0, the pressure is mainly in the circulation is mainly determined in the arterial system. So this is the mean arterial pressure. So you have here again the cardiac output. So again, rearranging the equation. So you have now the blood pressure now here is equal to, you have here the major determinants of the blood pressure. So you have the cardiac output and the total peripheral resistance. Okay. So now, as you can see here, the vascular resistance now this time in the pulmonary circulation. So the pulmonary vascular resistance, here you have the pressure on the right side, which is the pressure in the pulmonary artery coming from the right ventricle. So this is where the pulmonary circulation starts. And the end of the pulmonary circulation will be the left atrium. So as the pulmonary vein enters the left atrium. So the downstream pressure gradient will be found in your left atrium. Okay? So again, the pulmonary circulation is likewise determined by your cardiac output. Okay? So the pulmonary vascular resistance again will be directly related to the pressure difference between the pulmonary artery and the left atrium, and inversely related to your cardiac output. Okay? So this here, you have the three major adaptive changes when there is an increase in the pulmonary artery and the pulmonary vein pressure. Okay, so here you have the pulmonary artery. So here you have the pulmonary artery, and here you have the pulmonary veins. Of course, you have here the pulmonary capillaries. Okay, so when normally some pulmonary capillaries are actually closed. Okay, so there is no blood flow in this closed pulmonary capillaries. However, when there is an increase in the pulmonary artery pressure, there will be recruitment, meaning the closed capillaries will now open up, so there will now be blood flow in this area. Okay, so there will be an increase in the pulmonary blood flow. Okay, now further increasing the pulmonary arteries, you can see here there will now be distension. Okay, so individual capillaries will actually widen. Individual capillaries will widen and will acquire now a larger cross-sectional area. Okay, so this is for moderate to high levels. So there will be distension of the capillaries. Now, if you have very high if you have very high levels of pulmonary artery pressure, then this will cause likewise an increase in the pulmonary capillary pressure. So this will eventually cause transudation. So there will now be transudation of fluid into the interstitium. So this is capillary filtration. So if you remember, whenever there is an increase in capillary hydrostatic pressure under Starling forces, there will be an increase in the filtration of the fluid out of the capillaries. So there will be transudation of fluid in the interstitium, and this may lead to pulmonary edema. So these are the three major adaptive changes whenever you have an increase in the pulmonary artery pressure. Okay, so there will be recruitment followed by distension, and then eventually there will be transudation of fluid if the pulmonary artery pressure is very high. So going back now to the question, the pulmonary circulation. So here, the first option, it receives about 75%. So this is incorrect. So the pulmonary circulation actually gets 95% of the cardiac output per minute. Okay? So what about option B? It increases its resistance in response to increased cardiac output by vasoconstriction at the level of the pulmonary arterial. Okay, so actually in response to an increase in the cardiac output, meaning there is an increase in the flow. Correct. So from the Ohm's law, flow is equal to pressure difference divided by resistance. So flow is actually inversely related to resistance. So when you have increased flow, therefore the resistance will decrease. Okay. So again, this option is incorrect. Okay. So you have two other options. So for letter D, it decreases its resistance with increasing hydrogen ion concentration. So in this case, there's actually acidosis. So you have a decrease in the pH. So whenever you have acidosis or whenever you have acidemia, the resistance will actually increase because there will be vasoconstriction. Okay, so in presence of acidemia, there will be vasoconstriction. Therefore, the resistance will increase. So in this case, option D is also incorrect because it says here decreases resistance. Okay, so the correct answer here, therefore, would be letter C, decreased resistance in response to increased cardiac output by dilation and recruitment of pulmonary vessels. So again, increased cardiac output, increased blood flow, increased pulmonary artery pressure will cause dilation and recruitment of pulmonary vessels. So you have greater cross-sectional area, and vasodilation, of course, will decrease resistance. So again, the correct answer is letter C. Okay, so moving on to the next question, the best gas for measuring the diffusion capacity of the lung. So you have here the different gases, and at this point we now discuss diffusion limitation and perfusion limitation. Okay, so we move on to the next slide. So here we now differentiate perfusion limitation and diffusion limitation. So in perfusion limitation, there is faster equilibration of gas pressure between the alveoli and the capillary. So meaning at the end of the pulmonary capillary, the partial pressure of that gas is equal to the partial pressure of the gas in the alveoli. So they're equal now. Okay. What about diffusion limitation? So in diffusion limitation, gas pressure does not reach equilibrium at the end of the capillary. Okay, so to better understand perfusion limitation and diffusion limitation, let's go to the next slide. So this slide shows perfusion limitation exemplified by the gas nitrous oxide. Okay, so this is the nitrous oxide. So under normal resting conditions, the blood will actually move through the alveolar capillary membrane in only about 0.75 seconds. So this is the transit time of blood in the capillary. So only 0.75 seconds. Okay. Now, a major factor that will actually lead to faster equilibration of pressure is that the gas does not bind to hemoglobin. So your nitrous oxide does not actually bind to your hemoglobin. Okay? So in the arterial end of the capillary, you have here the nitrous oxide partial pressure, which is equal to 0. Okay? Whereas the alveolar pressure of your nitrous oxide is 10. So meaning there is a pressure gradient between the alveoli and the blood. Okay, so at the beginning of the capillary, because of that pressure difference, there will be fast diffusion of nitrous oxide. And since the nitrous oxide does not bind to your hemoglobin, its partial pressure in the pulmonary capillary blood will be rise easily. So it will rise very rapidly such that the pressure in the pulmonary capillary will be equal to that of the in the alveoli in only about 0.075 seconds. Okay, so here the partial pressure now of nitrous oxide is 10, same as the partial pressure in the alveoli. So in this case, you have equal pressure now. So the diffusion of nitrous oxide will now stop. Okay. Now at the end of the capillary, of course, you have the partial pressure of oxygen 10. So here in the it will exit the pulmonary capillary, and the partial pressure now is the same as that of your alveoli. Okay. So thus, in perfusion limitation, the transfer of gas is across the alveolo-capillary membrane is actually a function of the amount of the blood that will flow past the alveoli. Okay, so it is limited now by perfusion. Okay, so what about diffusion limitation? So in diffusion limitation, this is exemplified by the gas carbon monoxide. Okay, so in this case, there is no equilibration of the pressure at the end of the pulmonary capillary. So why? So your carbon monoxide binds to your hemoglobin. So actually, it forms a very strong bond with your hemoglobin. Okay. Now, if you look at the venous end of the pulmonary capillary, the carbon monoxide pressure is equal to 0. Okay, so same with your nitrous oxide in the alveoli, the partial pressure of carbon monoxide is 10. Okay, so again, there is a pressure gradient. So you have pressure gradient such that when the blood now enters the pulmonary capillary, this will cause the diffusion of the carbon monoxide out of the alveoli. Okay. However, as it diffuses out of the alveoli, it will immediately bind to your hemoglobin. Okay, such that the carbon monoxide now, the partial pressure will only increase very slightly. Okay, so as it keeps on diffusing out, it will continuously bind to your hemoglobin. So the partial pressure in the blood remains very low. So at the end of the pulmonary capillary, it does not reach the equilibrium. So in this case, the carbon monoxide partial pressure at the end of the capillary is only about 1 millimeter mercury. So there's still a pressure difference. So 10 millimeter in the alveoli and 1 millimeter mercury. So this is what you call diffusion limitation. So carbon monoxide is diffusion limited, and that it means that the movement of gas across the alveolar wall is actually a function of the integrity of the alveolar capillary membrane itself. So it's not dependent on perfusion, but rather it is a function of the integrity of the alveolar capillary membrane. So what about oxygen and carbon dioxide? So are they both perfusion limited, diffusion limited, or one is perfusion, one is diffusion limited? Okay. Now remember that one of the major factor affecting the equilibration of pressure is actually your affinity for hemoglobin. Okay. So if there's less affinity for hemoglobin, then it becomes perfusion limited. Now if it binds avidly to hemoglobin, just like your carbon monoxide, then it becomes diffusion limited. So remember, both oxygen and carbon dioxide also binds to hemoglobin. So does it mean they're diffusion limited? So not necessarily, because you have two other factors leading to faster equilibration of pressure, and that would be the pressure gradient and greater diffusion capacity. So the greater the pressure gradient, the greater will be the equilibration of pressure. Same thing with the diffusion capacity. So let's go now to oxygen and determine if it's really perfusion limited, mainly because of the pressure gradient. So here's a figure. So again, the transit of the blood in the capillary is still 0.75 seconds. But this time, the uh, venous pressure of your oxygen, the partial pressure in the venous blood is actually 40 millimeter mercury, whereas in the alveoli, it's about 100 millimeter mercury. So from 100 to 40, you have a very large pressure gradient. So at the beginning of the capillary, because of this pressure gradient, there is a rapid diffusion of oxygen. Even if it binds to your hemoglobin, because of the very large pressure gradient, it will continue to diffuse out of the alveoli across the alveolar wall, such that at 0.25 second, the partial pressure of the gas now in the capillary blood is the same as of that of in the alveoli. So remember, in nitrous oxide, the equilibrium is achieved at 0.075. Okay. Now for oxygen, the equilibrium is achieved at 0.25 seconds. So a bit slower than the nitrous oxide, primarily because of the high affinity of oxygen to your hemoglobin. But because of the very large pressure gradient, it will continue causing the diffusion of oxygen. So even if the oxygen, some of the oxygen binds to hemoglobin, so the remaining oxygen in the blood will contribute to the partial pressure of oxygen in the pulmonary capillary. So at the end of the pulmonary capillary, the pressure of oxygen in the blood is the same now as that of the pressure in the alveoli. So 100 here, and as the blood exits the capillary, you have the pressure of oxygen also 100 millimeter mercury. So in this case, the diffusion of oxygen is perfusion limited because there is equilibration of pressure as it reaches the end of the pulmonary capillary. Okay, so what about carbon dioxide? So going back to the factors leading to equilibration of pressure. So the second factor, there should be a large pressure gradient. Now, in the case of carbon monoxide, the venous carbon monoxide partial pressure is about 46. Okay. Now, the alveolar carbon dioxide pressure is 40. So meaning 46 to 40, you have a very small pressure gradient. But despite that, your carbon monoxide actually has a very high or large diffusion capacity. So diffusion capacity is actually this one defined by this equation. So you have here the rate of transport of gas, and here you have the pressure gradient. Okay, so this is actually based on the Fick's law. So let us review Fick's law. So as what we have said, the diffusing capacity of a gas is dependent on the variables affecting the Fick's law. So Fick's law states that the transport of gas or the diffusion of gas is directly proportional to the surface area, the diffusion coefficient, and the pressure gradient. And it is inversely related to the thickness of the tissue. Okay, so so earlier, I've mentioned that the carbon dioxide actually has a very great or a very large diffusion capacity, mainly because of the very high diffusion coefficient of your carbon monoxide. Okay, so compared to the other gases, so you have here carbon monoxide, the diffusion coefficient of carbon monoxide relative to the gas is relative to oxygen is about 20 times, okay, more than that of oxygen. Okay, so because of this high diffusion coefficient, therefore your diffusion coefficient now is increased, so therefore the diffusion of your carbon dioxide is also very high because of this high diffusion coefficient. So if you look at the other gases, so your carbon monoxide and your nitrogen here has also very low diffusion coefficient. So even though if the carbon dioxide binds to your hemoglobin, and even though if there is a small pressure gradient, it is still considered perfusion limited, mainly because of the high diffusion coefficient, which will increase its rate of diffusion and therefore its diffusing capacity. Okay? Here to show you the difference between oxygen and carbon dioxide in terms of the transport. The direction is opposite because that's what we have said earlier. In this case, the venous carbon dioxide is 46 and alveolar carbon dioxide is 40. So this time, so as the blood enters the pulmonary capillary, there is a pressure gradient that will drive the carbon dioxide out of the pulmonary capillary into the alveoli. Okay, so the direction is opposite. But since even though you have a small pressure gradient, it will still diffuse out of the alveoli, mainly because if the diffusing capacity is very large or very high. Okay, so such that there is the same pressure equilibration at 0.25, just like your oxygen. So at the end of the pulmonary capillary, you have here 40 millimeter mercury pressure in the blood, the same as that of in the alveoli. Okay, so in this case, your carbon dioxide is also perfusion limited, just like your oxygen and just like your nitrous oxide. So here is a summary of the partial pressure of gases if there is equilibration of pressure, so making it perfusion limited, or if there's no equilibration, making it diffusion limited. Okay, so again, nitrous oxide, you have a very rapid equilibration of pressures, as you can see here. About 0.075 seconds, you have already equilibration. Again, the main reason is that because your nitrous oxide does not bind to hemoglobin. Okay, so immediate rise in the partial pressure of the gas in the capillary blood. Okay, now your oxygen is likewise perfusion limited. So at 1/4, 0.25 seconds, your oxygen pressure will be the same as that of the alveoli, which is about 100 millimeter mercury. Again, the reason because of the very high pressure gradient from 40 to from 100 rather to 40. So the direction now will be towards the pulmonary blood. Okay. Now your carbon dioxide is likewise perfusion limited, but this time the direction is opposite. So again, even if the carbon dioxide is binds to hemoglobin, even if the pressure gradient is small, but because of the greater diffusing capacity, mainly because of the very high diffusion coefficient of carbon dioxide, so your pressure now will be equal to that of your alveoli, which is 40 millimeter mercury at the start of capillary, again at 0.025 seconds. Okay. Now, it becomes diffusion limited, so the transport of gas now will be a function of the integrity of the alveolar capillary wall rather than on the flow of blood in the pulmonary capillary. So this is exemplified by carbon monoxide. So again, because it strongly binds to your hemoglobin, so the partial pressure will only increase very slight in the pulmonary capillary blood. Okay, so it does not reach equilibrium at the end of the capillary. Okay, so those are the gases exhibiting perfusion limitation and diffusion limitation. Okay, so going back now to the question, the best gas for measuring the diffusion capacity of the lung. So you have your first nitrous oxide because it is usually diffusion limited. So we have already discussed earlier that nitrous oxide is perfusion limited. Okay, what about carbon dioxide? Carbon dioxide is also perfusion limited because it has high diffusion coefficient or larger diffusion coefficient. So this is incorrect. Okay, so A and B both incorrect. So this should be perfusion limited. This should be a very high diffusion coefficient. Okay. So you have your remaining two options, letter C and letter D. Now, helium is actually, helium behaves like your nitrous oxide. It does not bind to hemoglobin. So meaning, it is actually soluble in the blood since it does not bind to hemoglobin. So this option C is incorrect. Okay. So the correct answer therefore now will be letter D. So carbon monoxide, because it is vigorously bound by hemoglobin. So it's the best gas for measuring the diffusion capacity of the lung. So why? So going back to the diffusion capacity, so it's mainly defined by the rate of transport or diffusion of the gas divided by the pressure difference. Okay. Now remember that the carbon monoxide is diffusion limited. It binds to hemoglobin, such that the partial pressure of carbon monoxide in the at the end of the capillary is very low. So it's actually negligible. So in this case, it's zero. Okay. So you have this one, the factor now for the denominator. We do not measure anymore the pressure of carbon dioxide in the blood to estimate the diffusing capacity. Unlike in the other gases, for example, your oxygen and even your nitrous oxide, you have to take into consideration the denominator to determine the diffusing capacity. Okay, since we wanted to measure the diffusion capacity of the lung, so we use carbon monoxide since we will be able to correctly determine the rate of diffusion without minding the pressure difference in the capillary, between the capillary and the alveoli. So the correct answer here would be again letter D, carbon monoxide, because it's bound to hemoglobin, making it diffusion limited. So we do not need to measure the pressure of carbon monoxide in the blood to estimate the diffusing capacity. So it is the best gas for measuring the diffusion capacity of the lung. Okay, so do not confuse this with which of the gas has a greater diffusing capacity, because the answer would be carbon dioxide. In this question, what is being asked is the best gas for measuring the diffusion capacity of the lung, since the variables in the Fick's law, you cannot directly measure that. So instead, what we measure is the diffusing capacity. So in Fick's law, you have to measure the surface area, the thickness of the membrane. So we cannot directly measure that. So what we measure is the diffusing capacity instead. Okay. So the best gas for measuring this would be your carbon monoxide. Again, because the carbon monoxide is diffusion limited, so we do not take into account anymore its partial pressure in the blood. So it would be just the numerator, the rate of diffusion of the gas. Okay. So this next question is related to the previous one. So the following may result in a diffusion limitation of oxygen uptake. So the transport of oxygen is normally perfusion limited, but under certain conditions, it may become limited by diffusion. Okay, so it may become diffusion limited. Okay, such as, for example, when there are changes in the blood flow, or there will be changes in the integrity of the alveolar capillary wall. This will result in oxygen becoming diffusion limited. Okay, so here, so this is the normal alveolar capillary membrane. Now, if there are changes in the thickness of the alveolar capillary wall, such as in the presence of interstitial edema, okay, or there is fibrosis, there's thickening of the wall. So remember that in Fick's law, the rate of diffusion will be inversely related to the thickness of the membrane. So in this case, if there's increased thickness of the membrane brought about by fibrosis or by edema, then it will decrease the rate of diffusion. Okay. Now, also, if there will be a decrease in the surface area. So again, in Fick's law, it is directly related to the surface area. So if there is a decrease in the surface area of the alveoli, there will be a decrease also in the rate of diffusion of the gas. Okay. So here you have atelectasis. This will decrease the surface area. Same thing with pneumonia and pulmonary edema, the presence of secretions within the alveoli, or if there is destruction of the alveoli. So this will lead to the decrease in the surface area. Again, the rate of gas transport or the rate of diffusion will now be decreased. Okay. So here, so at this point, just to show you the effect of increase in the thickness of the membrane in the alveolar capillary wall. So here, due to alveolar thickening. So even though if you have a very high pressure gradient from 100 to 40, the diffusion will still be slower, okay? Such that because of the alveolar thickening. So remember, that's a factor. Diffusing capacity is a factor in equilibration of pressure. But because of the alveolar thickening, your pressure now will not be equal in the arterial end. It will not be equal to the alveolar pressure. Okay, so here you have 60, here you have 100. So in this case, oxygen becomes diffusion limited. Okay. What about if there are changes in blood flow? So for example, when you exercise. So in exercise, there's an increase in the cardiac output. Okay, so here there is still equilibration of pressure. So here 4100. But the blood will flow really fast. So the transit time is decreased to 0.25 seconds. So that's the time needed for equilibration of pressure for your oxygen. But as you can see here, so there's still equilibration of pressure at 0.25 seconds, but it happens already at the end of the capillary, not at the start of the capillary, about 1/4 from the beginning of the capillary, but rather at the end of the capillary. So here, it becomes, it's still perfusion limited. So 100 and 100 millimeter mercury. Okay? So what about exercise at extreme altitude? So in cases of at high altitudes, the alveolar pressure is usually low. So it's not really 100 because of the low barometric pressure. Okay. Now, what happens is that when you exercise in the at the alveolar at high altitude, it will be very difficult to reach pressure equilibration because of the smaller pressure gradient. So let's say the alveolar pressure is only about 70. Okay. So 70 and in the venous end it's 40, so you have a much smaller pressure gradient. So it is possible that you will not reach equilibration of pressure at the end of the capillary because the smaller pressure gradient will slow down the diffusion of the oxygen into the alveolar wall. Okay. So here, just to show you again, in oxygen, so oxygen is mainly perfusion limited, just like nitrous oxide. But in the presence of pulmonary condition, it becomes diffusion limited. So it does not, so here, end of capillary, it does not reach 100 millimeter mercury. What about carbon dioxide? Okay. So carbon dioxide, is it possible that it becomes diffusion limited? So remember that carbon dioxide has a very large diffusion coefficient and therefore very high diffusing capacity. So it's normally perfusion limited But even in the presence of pulmonary disease, because of the high diffusivity of your carbon dioxide, it remains to be perfusion limited. Okay, so as you can see, you will still achieve equilibration of pressure, albeit much slower as compared when you do not have a pulmonary condition. But still, you will achieve the pressure equilibration. So it remains to be perfusion limited. Whereas your oxygen in the presence of pulmonary disease, it becomes diffusion limited. So the patient can develop hypoxemia without hypercapnia because you can exhale the carbon dioxide into the alveoli because of its greater diffusivity, and still it remains to be perfusion limited. Now, this question. The following may result in diffusion limitation of oxygen uptake. So the first option, interstitial pulmonary fibrosis. It will cause alveolar thickening, right? So alveolar thickening will reduce the transport of oxygen such that at the end of the capillary, it will not achieve the same pressure as that of the pressure in the alveoli. So this, in this case, oxygen will be diffusion limited. Second one, high cardiac output states in the presence of increased thickness of the alveolar capillary membrane. So increased thickness already, that's already a clue. So meaning it becomes diffusion limited. Further increasing cardiac output will also increase the blood flow into the capillary. So this will lead to further making the oxygen diffusion limited. Letter C, exercise at extreme altitude. So as what I have mentioned earlier, exercise will decrease the transit time. And in the presence of low oxygen pressure in the alveoli, this will create a smaller pressure gradient. Therefore, the oxygen now will become diffusion limited. So the correct answer here will be letter D, all of the above. Okay? Now, this is the last question. Most of the venous carbon dioxide is in the form of, so you have here the different forms of carbon dioxide. So as what I have said earlier at the start of the lecture, your carbon dioxide will diffuse into the blood and about 90% will actually enter your RBC. So here you have the carbon dioxide. As a waste product in the cell, it will diffuse into the interstitium, into the blood now, okay? So in the blood, it will bind to your hemoglobin in about 23%. So this will be your carbamino compounds. And the rest, a big chunk of it will bind with your water to form your carbonic acid. And this will, under the influence of the enzyme carbonic anhydrase. So the carbonic acid will spontaneously dissociate into bicarbonate and the hydrogen ions. So the hydrogen ions will now bind to your hemoglobin. So as I've said, binding of hydrogen with your hemoglobin will alter the conformation of the hemoglobin. So there will be decreased affinity of your oxygen to your hemoglobin. So that's the Bohr effect. And what about the bicarbonate? So 70% of the bicarbonate formed from this reaction, it will diffuse out of the cell RBC. So in exchange, your chloride will go into inside the RBC. So to maintain electrical neutrality, again, this exchange is what you call the chloride shift or the hamburger phenomenon. So going back to the question, most of the venous carbon dioxide is of course in the form of, correct answer, letter B. So 70% bicarbonate, only about 7 to 10% dissolved in plasma. The rest will enter the RBC. 20% will form carbamino compounds by binding with your hemoglobin. And the rest will be formed from the reaction carbonic acid. So you have now bicarbonate and hydrogen. So bicarbonate will exit the cell. So 70% of that bicarbonate. So that's from the carbon dioxide. So it is most of the venous carbon dioxide is in that form. So this is the end of a review on respiratory physiology. So I hope you learned something. Thank you very much.
Okay, are there any questions? Wala po, maliwanag ba? Okay, no technical issues? Wala naman, okay? So we'll have a 10-minute break, is that okay? So pwede naman kayo kumain habang nakikinig. So what time is it now? It's 9:53. So 10:03, can you come back? Okay, sige, 10 minutes. Okay, everyone, are you back? So let's proceed to the second part of this review, cardiovascular physiology. Okay, so I'm sharing my screen now.
So let us now proceed to the review on cardiovascular physiology. So here's the first question. Put the following events in their proper order. So you have here CAV waves. So these are the waves that you see in a right atrial pressure curve tracing. And this is likewise the waves that you see in the jugular venous pulse. So remember that the veins drain into or ends in the right atrium. So the pressures in the right atrium will be likewise transmitted back to the venous system. So in this case, this will be the waves that you will also see in the jugular venous pressure curve or jugular venous pulse. Okay. Now here we have the, of course, you're already very familiar with this. These are the waves that you see in an electrocardiogram tracing or your ECG. Okay. So you have to put the following events in their proper order. So you have here four choices. So before we answer this one, let's go first to the Wigger's diagram. So let us review the Wigger's diagram. So this is the Wigger's diagram. So it actually shows the events in the cardiac cycle as a function of time. So you have here the period of systole divided into the isovolumic contraction phase and the ejection phase. Now, here you have the much longer period of diastole, which is divided into the phase of isovolumic relaxation and the ventricular filling phase. Now, the ventricular filling phase is further subdivided into the rapid inflow, slow diastasis, and atrial systole. Okay. Now, here the first three curves here corresponds to the pressures in the aorta. So this is the one, the topmost, and then the red one is the ventricular pressure curve. So that's one, and the lowermost, the black dotted line, is the atrial pressure curve. Okay, so this blue line corresponds to the ventricular volume. Here you have the ECG waves, and then here you have the heart sounds as picked up by the phonocardiogram. Okay, so if you look at this latter part, so this is diastole. So if you look at this latter part of diastole, so it's the same as this one. So we'll start discussing the cardiac cycle with the latter part of the diastole. Okay, so here you have an increase in the an increase in the atrial pressure. So it's actually greater than the ventricular pressure. So this is very important. If the upstream pressure is greater than the downstream pressure, in this case, the atrial pressure is greater than the ventricular pressure, this will keep the AV valves open. So your mitral and tricuspid valves. So this will continue, so the blood now will continue to flow down from the atria into your ventricle. Okay. Now, towards the latter part, again, as I've said, of the diastole, there will now be depolarization of the atria. So the impulse will be coming from the SA node, and the depolarization will spread to both atria, resulting into your P wave. Okay. So of course, after atrial depolarization, you have now atrial contraction. So here you have the period of atrial contraction, and this is the period of atrial systole. So here you have an increase in the atrial pressure. So this corresponds to the A wave of the atrial pressure curve. So again, this is atrial contraction. Okay. So as the atria contracts, it will push more blood into your ventricle. So an additional 20% of blood from the atria will be pushed down into your ventricles. Okay, so this is very important because the additional amount of blood will further stretch the myocardial fibers. So the stretch of the myocardial fibers will lead to a generation of both the passive force and the active force. So for the passive force, so this is the force that will try to overcome the stretching of the myocardial fibers, and with the generation of the passive force there will be a slight increase in the ventricular pressure. Okay, whereas the active force is also important, so when the ventricles start to contract, there will be a generation of a greater active force if you have uh, optimal length of the myocardial fibers as brought about by the increase or additional amount of blood. So you have adequate or optimal stretching of the fibers, which will generate greater active tension and therefore greater force of contraction. Okay, so at this point there will also be the depolarization will also spread down the ventricle. So you have here now the QRS wave in the ECG. So of course, ventricular depolarization will also be followed by ventricular contraction. So this increase in ventricular pressure brought about by the atrial contraction, which serves as the booster pump that will cause the stretching of the myocardial fibers brought about by the additional amount of blood, together with the ventricular depolarization, will result in the ventricular pressure to be greater than your atrial pressure. So at this point, you will have closure of the AV valves, and this is heard as the first heart sound or the S1. So here you have the S1, okay? So at this point, you enter now the period of systole, starting with the period of isovolumic contraction. So as you can see, during the period of isovolumic contraction, there is rapid rise in the ventricular pressure, okay, brought about by the ventricular contraction. But this is just an isometric form of contraction. So meaning there is buildup of tension, but there is no shortening yet of the muscle. So why? Remember that the AV valves are still closed at this point, and semilunar valves, the aortic and the pulmonary valves, are still closed as well. So it has not opened yet. So in this case, because of all the valves are closed, you have the volume in the ventricles to be of the same amount. Okay, so here you have, so that's why it's also called isovolumic or isovolumetric contraction. So this is actually your end diastolic volume. So there's no change in volume within the ventricle during this phase. Okay, now, but as you can see here, there will also be a slight increase in atrial pressure during the period of isovolumic contraction, mainly because as the ventricles contract here, the increase in the tension in the ventricle will push the AV valves towards the atrium, and this will cause an increase in the right atrial pressure. So this is your C wave. Okay, so this is the C wave of the atrial pressure curve. Okay, now when the ventricular pressure now is greater than the aortic pressure, you have now the opening of the aortic valve. Okay, so this will lead to the ejection of the blood or pumping of the blood out of the heart into the aorta. Okay, so here, during this period, as you can see, as we push the blood into the aorta, there will be a corresponding increase in the aortic pressure. But if you look at the ventricular pressure, it will continue to rise. Okay, so the maximal or the peak ventricular pressure is likewise seen in this period of ejection. Now, towards the latter part of ejection, of course, at this point, the ventricles will start to relax. So you have here the T wave, okay, corresponding to ventricular repolarization. So this will result in a fall in the ventricular pressure, okay? So when the ventricular pressure now is much lower than the aortic pressure, of course, there will be closure of the aortic valve, and this is heard as the S2 or second heart sound. Okay. Now, this is now the period of diastole. So this is the period of isovolumic relaxation. So, but if you take a look at this one, you have here a a notch. We call this necrotic notch or the incisura. So this corresponds to abrupt cessation of flow of your blood from the aorta into the ventricle. So remember, this latter part, the aortic pressure is already greater than the ventricular pressure, so there's already backflow of blood into the ventricles. But as soon as the aortic valve closes, there will be abrupt cessation of that backflow, so the blood in the aorta will cause a slight increase in aortic pressure before the blood moves forward the arterial system. So this is the reason why you have your necrotic notch or incisura. Okay, so during this period of isovolumic relaxation, also you have no change in the volume. So this is your end systolic volume because all the valves are closed. Okay. Now there is also another wave seen in the atrial pressure curve, and this is the V wave. So the V wave is due to the pooling of blood in the right atrium. So remember, during this period, all the valves are still closed, but the venous return is continuous. So the blood now will pull in your right atrium, and the increase in the volume of blood in your right atrium will cause an increase in the right atrial pressure. So actually, you need this increase in the right atrial pressure such that it will now exceed the ventricular pressure. So at this point, it will now exceed the ventricular pressure. So this will lead to opening now of your AV valves. Okay, so when the AV valves opens, you now have the ventricular filling phase. So of course, the first one is the rapid inflow. So you have an increase in the amount of blood in the ventricle. So you have the fast flow of blood, and then you have the slower diastasis, and lastly, again, when the atria is depolarized, you have the atrial contraction. So this is the period of atrial systole, again adding additional 20% of volume of blood in the ventricles. Okay, so this is the Wigger's diagram. So put the following events in their proper order. So which one comes first? Is it the ECG waves or the atrial pressure waves? Okay, so which one do you think? So it is actually the ECG waves first. So remember, you have the P wave first. Okay, so this corresponds to atrial depolarization, followed by atrial contraction, which is seen as the A wave. Okay, so after atrial contraction, you will have ventricular depolarization. So this is the QRS, followed by the ventricular contraction. And the ventricular contraction will likewise increase the right atrial pressure, mainly because the tension in the wall, ventricular wall, will push the valves into the atrium. So you will have a slight increase in right atrial pressure. So this is the C wave. Okay, and then you have the period of ventricular depolarization, and this will be followed by the V wave. So during the period of isovolumic relaxation, there will be pooling of blood in the right atrium, which will cause a slight increase in the right atrial pressure. Okay, so if we follow the order, so first you have 4, and then 2, and then 5, and then you have the contraction, C wave, and then followed by, of course, T wave, and then the V wave. Okay, so the correct answer here will be letter A. Okay, so those are the events in the cardiac cycle. So before we go to the next question, let us review the pressure-volume relationship. So the pressure-volume relationship is one way of assessing the myocardial performance. So you have here the left ventricular pressure. So this is the red one. And then, of course, the blue line will correspond to the left ventricular volume. Okay. So here's the next question. The plateau of the action potential is caused by. So here you have the different ion conductance. So let us now review the action potential in cardiac muscle. So there are actually two types of cardiac muscles. So the first type of cardiac muscles are your slow response nodal cells. So these are your SA node, AV node, and Purkinje fibers. So they are considered specialized muscles for conduction purposes only. Why? Because they exhibit very few myofibrils and therefore they only exhibit feeble contractions. So they're more important instead for conduction of the impulse rather than contraction. So the second type would be the fast response muscle fibers, which are the non-nodal cells. So these are the atrial muscle and the ventricular muscle. Okay, so they are considered non-specialized muscle for contraction purposes, so meaning they're more important for actual contraction. Okay, now if you look at this figure here, uh, during the resting state of the cardiac muscle, your potassium channels are open. So here you have closed sodium and calcium channels. But when the cells, cardiac muscle cells, become depolarized, you can see that it's not only the sodium channels that will open, but you also have the opening of the calcium channels. Okay, so during depolarization, also you have the closure of the potassium channels. So this is very important. Unlike in skeletal muscles, it's mainly the opening of the sodium channels during depolarization. So for the cardiac muscle, it's the opening of both the sodium and calcium channels. Okay. Now, since you have two types of cardiac muscles, you also have two types of cardiac action potential. So we'll go to the action potential of the action potential of the slow response nodal cells. So let's start with the action potential in the nodal cell. So in the SA node and AV node primarily. So you only have three phases. You have phase 4, 0, and 3. Okay. So the phase 4 is the resting membrane potential. But supposedly the phase 4 should be flat. But in this case, if you look at this figure, there's a slow rise in the membrane potential in phase 4. Okay. So this is brought about by the opening of the funny sodium channels. So if you remember funny sodium channels, so these are actually slow sodium channels that will permit now entry of sodium into the cardiac muscle cell. So you have slow depolarization. So that's why, as you can see, you have now a less negative resting membrane potential or less negative membrane potential, and it's now much closer to that threshold. Okay, so once it reaches the threshold, once the voltage reaches the threshold, then you have now the opening of the calcium channel. So this is now your phase 0. Okay, so as you can see, the opening of calcium channels actually slow. So you have a less steep upstroke of the action potential. Okay, so as soon as it reaches a certain voltage at this time, there will now be opening of the potassium channel. So you have now the phase 3, which is the repolarization phase. So this permits the efflux of potassium out of the cell. So your membrane potential now becomes again negative. Okay, so it will become more negative until again it reaches the phase 4. Okay. So when it reaches this certain voltage, it will open the funny sodium channels again. So you have now again the slow rise in the membrane potential in phase 4. Okay. Now for the non-nodal cells, so this is the action potential, you actually have 5 phases. So here you have the complete phases 4, 0, 1, 2, 3. Okay, so here if you look at phase 4, this is the true resting membrane potential. Okay, so there's no funny sodium channels here in the atrial and ventricular muscle. So instead, the phase 4 is due to the usual opening of the potassium channel. So just like in your skeletal muscles. Okay. So once a signal or an impulse reaches the atrial and ventricular muscle, then it will permit the opening of the sodium channels. Now, so these are the fast sodium channels. So as you can see, fast opening of the sodium channels, there will be a step upstroke of the action potential. Okay, so as compared to the action potential of the nodal cells, the upstroke is actually less steep, okay? And this phase zero of the depolarization state of the nodal action potential is primarily due to the opening of the calcium channels. But for the non-nodal cells, for the atrial and ventricular muscle, the phase zero this time is brought about by the opening of the fast sodium channels, okay? So not the calcium channels, okay? Now, when it reaches a certain voltage, there will be a transient opening of the potassium channel. So you have now the phase one. So it will permit the efflux of potassium. And then at a certain voltage, you have now the opening of the slower calcium channels, so slow to open calcium channels, which will now try to oppose the efflux of potassium. So if you have efflux of potassium, you have influx of calcium. So your membrane voltage will be more or less the same. So that's why this is the plateau part, which is your phase 2 and primarily brought about by the calcium influx that will oppose the efflux of potassium. Okay. Now, at a certain point, you will have more opening of the calcium channel. So you have the continuation of the repolarization process. So this is again phase 3. And when it reaches a certain voltage, again, it will now, you now have again the resting membrane potential. You have now the phase 4, okay? So going back to the question, the plateau of the action potential is caused by, so you have here, increase in the ion conductances. So as what we have said, the plateau is only found in the action potential in your atrial and ventricular muscle. So these are the non-nodal cells. So this is the phase 2 plateau, and it's primarily due to, what's the correct answer? So it's due to the calcium influx. Okay, so sodium conductance is the phase 0 of action potential in the non-nodal cells, the fast conducting as of the fast muscle fibers. Potassium conductance is a repolarization phase. So this is the phase 3 of both the action potential in the nodal and the non-nodal cells. And chloride is not actually involved in generation of the action potential. Okay, so the correct answer here would be letter C. So proceeding to the next question. So if the end diastolic ventricular volumes are increased within physiologic limits, so the primarily this end diastolic volume will be responsible for the preload, right? So it's dependent on the right atrial pressure and right atrial volume. Okay, so if it is increased, what will happen now? So will there be an increase in the stroke volume, cardiac output, or will there be a decrease in the venous pressure? Or letter D, the output of the left ventricle will exceed that of the right ventricle. Okay. So let's just review the terms. So end diastolic volume is the blood in the ventricle at the end of ventricular filling. So this will determine the preload or the stretch of the myocardial fibers. And as I've said earlier, it is primarily determined by the volume and by the pressure in the right atrium. Okay, and systolic volume is of course the amount of blood at the end of systole, and ejection fraction is the fraction of the EDV that is pumped out each time the ventricles contract. So if you look at this formula, ejection fraction is actually the difference between EDV minus ESV. So that's actually your stroke volume divided by your end diastolic volume. So the normal ejection fraction is about, it ranges from about 55 to 70%. Okay, so when you have your ejection fraction at that within that range, then meaning your ventricles are performing well. Okay, so you have good performance of your myocardium. Now, what is CVP? So this is the pressure in the right atrium and of course the vena cava. Preload is, as what I've said earlier, this is the length of the muscle at the onset of contraction, which will be responsible for generating the amount of tension, active tension, and eventual force of contraction based on your Frank-Starling law. Afterload is the resistance that must be overcome by the contracting ventricular muscle, okay, during the ejection. So this is mainly determined by the aortic pressure or arterial resistance, okay? So factors that control cardiac output, you have the cardiac factor. So this will be your heart rate and myocardial contractility. So if you remember, cardiac output is equal to heart rate times stroke volume. Okay, so stroke volume is primarily a function of your myocardium. So when you have good contractility, you have good stroke volume. But the contractility will actually be dependent on two other factors. So you have here the preload and afterload. So these are the coupling factors. So remember, greater preload, greater force of contraction. This is Frank-Starling law. Okay, so when you stretch the myocardial fibers, you increase the preload and therefore you increase the active tension and you increase the force of contraction. Now, what about afterload? So the afterload is a resistance. So a decrease in afterload will increase the myocardial contractility. Okay, so you do not want an increase in afterload because it will decrease the myocardial contractility. Okay, so preload and afterload will also um, affect the cardiac output primarily because of its effect on the contraction of the myocardium. This is the Frank-Starling law again. So as you increase the right atrial pressure, you increase the velocity of blood flow from the atria down to the ventricle. So you have greater end diastolic volume, which will increase the myocardial stretch. Okay. So as you increase the myocardial stretch, you also increase the contractility of the muscle, of the ventricular muscle. So therefore, you increase the stroke volume or your ventricular output. So going back to the question, if the end diastolic volume are increased within physiologic limits, so you have here the four choices. So what do you think is the correct one? So again, an increase in end diastolic volume will increase the stretch of the myocardial fibers and therefore will increase the preload, which will increase the active tension and eventual force of contraction in the ventricular muscle. So if you read the choices here, the correct answer will be letter A. So the stroke volume would be increased. So if the stroke volume is increased, of course, you expect the cardiac output to increase. Okay, so the venous pressure will likewise be increase if you have an increase in the blood flow in the peripheral circulation, then it would likewise cause an increase in the pressure in the venous system. Okay, and then lastly, the output of the left ventricle would exceed that of the right ventricle, so this is also incorrect. Again, the correct answer is letter A. So here's the next question. The most important cause of increased blood flow to a working skeletal muscle during exercise. So you have here four options. Okay. So the control of the rate of blood flow can either be acute or long-term. So for the acute control, you have three factors. So you have the local, humoral, and neural. So for local, whenever you have an increase of cellular activity, of course, you have an increase in the metabolic rate, which will cause vasodilation. So we already know this. You have a vasodilation. And with vasodilation, you will have a decrease in the resistance. So here, resistance to flow, you have here the formula. So resistance is inversely related to the radius of the vessel. So when you have vasodilation, you have increased radius, and of course, this will decrease the resistance. So when you have decreased resistance, you will now have an increase in the blood flow. So again, this is Ohm's law. Okay. Now, humoral, of course, you have vasodilators, which will induce vasodilation, and lastly, you have the neural mechanism. Okay. So normally, your SNS actually causes vasoconstriction. Okay. However, in the muscle arterioles, it actually causes vasodilation. So this is the via the beta receptor. So via alpha receptors, the SNS will cause arteriolar constriction, but you have beta receptors in the muscle arterioles that will cause now vasodilation. So only in the muscle arterioles where you can have vasodilation as an effect of the sympathetic nervous system. Okay. Now, of course, for the long-term control, an increase in the blood volume will increase your venous return, your preload cardiac output, and an increase in the cardiac output will of course cause vasodilation and an increase in the blood flow. So here, just to show you, these are the vasodilators, mainly as products of cellular metabolism. So you have here your adenosine, your hydrogen ions, carbon dioxide, and potassium. So these are all products of cellular metabolism, and they will cause relaxation of the smooth muscle, therefore will cause vasodilation. Okay? So if we go back to the question, the most important cause of increased blood flow through a working skeletal muscle during exercise. So you have your increase in the cardiac output, sympathetic vasodilator effect in the muscle, vasoconstriction in the viscera, and products of local metabolism. So of course, we already know that the most important cause of increased blood flow is vasodilation. So letter C is already incorrect. Okay, so you have here an increase in the cardiac output will also increase the blood flow. Same with D, vasodilation will also increase the blood flow, and letter D, products of local metabolism. Okay, so all of these three, A, B, and D, these are all correct, but the best answer, so initially, the best answer, of course, would be an increase in the cellular activity, producing now, you have now products of local metabolism. Okay, so this is the most immediate factor that will increase the blood flow. So increase cellular activity will, of course, you have the waste products, carbon dioxide, hydrogen, adenosine. So these are all vasodilators. So this is the most important acute control, okay, in the rate of blood flow. So we go now to this next question. Which of the following factors is responsible for the ascites and edema in liver cirrhosis? Okay, so you have here the different pressure, venous pressure, filtration pressure, and oncotic pressure. Okay, so to answer this question, we have to review starting forces. So the movement of fluid from the capillary into the tissues is actually governed by starting forces, which is a balance between the oncotic pressure and the hydrostatic pressure, both in the blood and in the interstitium. Okay, so an increase in hydrostatic pressure will actually promote capillary filtration, so meaning it will push the fluid out of the interstitium. So this is very important. At the arterial end of the capillary, you push the fluid. Of course, it contains the oxygen and nutrients required by the tissues, and this will be used now by the tissues. But at the venous end, you have to pull back the fluid. So this time, an increase in the oncotic pressure will pull the fluid back into the capillary. So it will now go into the venous system. So to make it simple, actually the oncotic pressure and the hydrostatic pressure in the interstitium is negligible. It's very small. So in determining the net driving force, so this is the net driving force, we only look at the pressure in the capillary. Okay, so the net driving force is actually the difference between the capillary hydrostatic pressure and the plasma oncotic pressure. Okay, now here is the arterial end of the pulmonary capillary. So if you look at the hydrostatic pressure, it's about 30 millimeter mercury, whereas the oncotic pressure is only 22. Okay, so in this case, the difference will be 8. So this will be the net driving force. So it's positive. So it will push the fluid out into the interstitium. Okay, Now, towards the venous end now, so this is the venous end of the capillary, the hydrostatic pressure now will go down. So in this case, from 30, it will become 15, but the oncotic pressure, of course, remains the same. Okay, so this is the dependent on the proteins in the blood, so it will not really change. Okay, so at this time, the difference now will be 15 minus 22, it's negative 7. Okay, so if it's negative, now it will mean a reabsorption of the fluid back into the capillary. Okay, so if the net driving force is positive, it will promote capillary filtration. If it's negative, so less than 0, it will promote capillary reabsorption. So at this point, the venous end, you have reabsorbed the fluid back into the interstitium. Back into the capillary. So going back now to the question, which of the following factors is responsible for the ascites and edema in liver cirrhosis? So when you say you have ascites and edema, mainly there's an increase in the interstitial fluid. Okay, so what are the possible causes of increased fluid in the interstitium? One is that there could be an increase in the capillary hydrostatic pressure, so it will push the fluid out into the interstitium, or an increase in capillary filtration. Or second, there will be a decrease in the oncotic pressure. Therefore, there will be a decrease in the reabsorption of fluid from the interstitium. Okay, but it says here the condition is actually liver cirrhosis. So what is the problem when you have liver cirrhosis? So liver is the site where you have protein synthesis. So when you have liver cirrhosis, there is a decrease in protein synthesis. Therefore, it will decrease the oncotic pressure in the blood. Okay, so the correct answer here, therefore, will be letter C, decrease oncotic pressure. Okay, so as I've said earlier, fluid in the interstitium can also be caused by an increase in the capillary filtration. But since the question here is the condition here is liver cirrhosis, so we can rule this out. Decreased venous pressure will actually promote capillary reabsorption. Okay, so when you have capillary reabsorption, of course, there will be no fluid in the interstitium. So this is likewise incorrect. And then the last option is also incorrect because viscosity is not a factor that will determine the movement of fluid in and out of the vascular system. Okay. So we go now to the next question. So here you have 24-year-old man who was shot several times. So on examination, he was pale looking. He was breathing rapidly, and there's a continuous bleeding from multiple wound sites. So you would suspect that this patient is actually suffering from hemorrhage. Okay, so what would be least expected in this patient? So you have here the 4 choices. So we go now to the discussion. What will happen actually when you have a hemorrhage? Of course, there will be a decrease in the blood volume. Okay, so there will be compensatory mechanisms when you have this condition. So here in hemorrhage, of course, you will have a decrease in intravascular volume, and a decrease in intravascular volume will decrease your mean systemic filling pressure, and therefore a decrease in the venous return. So remember that the factors affecting mean systemic filling pressure, one of them would be the volume. Okay, the other one is the capacitance. Okay, so when you have decreased volume, decreased filling pressure, therefore decreased venous return, which will decrease the preload. So this will decrease now the ventricular wall stretch, of course, and decrease the force of contraction, which will decrease the cardiac output and a decrease in arterial pressure. Okay, so when you have a decrease in arterial pressure, of course, this will be sensed by the baroreceptors. Okay, so there will be decreased firing. So remember, the baroreceptors will only fire whenever there is an increase in arterial pressure. But since you have a decreased arterial pressure, there will be decreased firing. And since baroreceptors normally inhibit your medullary cardiovascular control center, now when you have decreased firing, therefore there will be disinhibition. So you have now increased activity in the medullary cardiovascular control center, which will increase now the sympathetic outflow. Okay, now there are other receptors, so particularly your cardiopulmonary receptors, which are found in the right atrium. So when you have a decreased right atrial pressure, secondary to decreased venous return, there will be decreased firing of the cardiopulmonary receptors. So these are the low pressure receptors found in the right atrium. So again, it normally inhibits the sympathetic activity. So this inhibition now when you have decreased firing, so just like your baroreceptors. At the same time, because of the decreased cardiac output, you have now a decrease in the PO2 levels because of a decrease in the blood flow, which will also increase the carbon dioxide. Okay, so this will stimulate the chemoreceptors, and usually the increased firing of these chemoreceptors will increase the sympathetic activity. Okay, so what will happen now when you have increased sympathetic activity? So you have the effects now both in the heart and in the vascular system. So in the heart, it will increase the heart rate. So remember the effect of sympathetic activity in the heart. It will both increase the heart rate, so the rate of contraction plus the force of contraction, which will now increase the cardiac output. Okay. What about in the vascular system? It will promote constriction. So here you can see here you have arteriolar vasoconstriction, which will increase the total peripheral resistance. Okay. So going back to the question, a 24-year-old man was shot several times. So here you have hemorrhage. So what would be least expected in this patient? Okay, so do you expect vasoconstriction? So yes, because of the increase in the sympathetic activity as a compensatory mechanism, there will be an increase in the total peripheral resistance brought about by vasoconstriction. Okay, so option B, a decrease in arterial pressure, of course, hemorrhage. So even if you have a sympathetic compensatory mechanism, but you still have the hemorrhage, so your arterial pressure will still remain very low. Okay, so you only have two other options. So an increase in baroreceptor firing and an increase in heart rate and contractility. So which do you think is the correct answer? So it's letter C. So this will not be this option is not expected in a patient with hemorrhage, because in a patient with hemorrhage there will be a decrease in the arterial pressure, therefore decrease firing of the baroreceptors. Okay. Now option B is also expected in this patient mainly because of the sympathetic activity, the increased sympathetic activity because of the decrease in the baroreceptor firing. Okay. So remember, decreased baroreceptor firing will lead to loss of inhibition in your sympathetic center or in your cardiovascular center in the medulla. So it will increase the sympathetic outflow and will now increase heart rate and contractility. So in this case, the least expected in patient with hemorrhage would be letter C, an increase in afferent baroreceptor firing. Moving on. So here's the next question. In the presence of high CVP, so CVP or right atrial pressure, so you can use the two terms interchangeably. So the following cardiovascular parameters will increase except. So again, the exception, what is the exception here? Okay, so you have here four choices. So let's go back again to the Ohm's law. So Ohm's law, the flow is directly related to the difference in the pressure from one end to the other end, and it's directly related to resistance. Okay, so you're already very familiar with Ohm's law. So we can actually apply Ohm's law again in our systemic circulation. So this time, the flow now will be determined by your cardiac output. So the blood flow in the circulation will be determined by your cardiac output. And of course, for the systemic circulation, the pressure now will be on the right side, or sorry, on the left side from the aorta, and it will end in the right atrium on the right side of the heart. Okay, and this one, the resistance, of course, is determined by the total peripheral resistance or your systemic vascular resistance. So rearranging this equation again, your blood pressure is equal to cardiac output times total peripheral resistance. So remember the determinants of the blood pressure. You have your cardiac output and total peripheral resistance. Okay. Now, so we can also apply Ohm's law. So Ohm's law in the venous return or the return of the blood back to the heart. So this time the flow will be your venous return. So here, so venous return is equal now. So what will determine now the pressure gradient? So it's actually coming from the peripheral veins, and the peripheral venous pressure is determined by your mean systemic filling pressure minus, of course, the downstream end will be your right atrium. So right atrial pressure, and the denominator here will be the resistance to the venous return. Okay, so when you have changes in the right atrial pressure or central venous pressure, there will be a corresponding change in the venous return. So for example, when you have increase in the right atrial pressure, so what will happen to the pressure gradient? It will decrease. Okay, so this will now lead to a decrease in venous return. So again, an increase in right atrial pressure will decrease the pressure gradient that will drive the flow of blood back to the heart. Therefore, you decrease your venous return. Okay. Now, when you have a decrease in the venous return, what will happen? Of course, there will be an increase in the peripheral venous pressure. So going back to the Starling forces, so in starting forces, so you have here the capillary, you have here the arterial end, the venous end. In the arterial end, you have an increase in capillary hydrostatic pressure. So the net driving force is positive and it will promote capillary filtration. Now, in the venous end of the capillary hydrostatic pressure now will go down, and therefore the net driving pressure now will be negative. So meaning there will be no more capillary filtration. Instead, there will be an increase in reabsorption of the fluid back into the capillary. Okay. So what will happen now when you have an increase in the venous, when you have an increase in the peripheral venous pressure? So if you look at this one compared to this one, if you have an increase in the peripheral venous pressure, the venous end of the capillary will likewise increase. So as you can see now, you have here an increase in capillary hydrostatic pressure, and the net driving force now will still be positive. So therefore, it will drive the fluid out of the interstitium. So you still have capillary filtration. Okay. So this will lead to actually fluid in the interstitium, and it can actually cause edema. So if we go back to the question, in the presence of the high central venous pressure or right atrial pressure, so you can use the two terms interchangeably, the following cardiovascular parameters will increase except. Okay, so of course, when you have an increase in the right atrial pressure, this will actually decrease the pressure gradient that will drive the flow of the blood back to the heart. So meaning a decrease in the pressure gradient will of course decrease your venous return. So when you have a decrease in venous return, you have an increase in the peripheral venous pressure. Okay, so this will likewise increase the hydrostatic pressure in the venous end of the capillary. And when you have an increase in the capillary hydrostatic pressure, of course, you have an increased capillary filtration. Okay, so all of this will increase except again venous return. Okay, so the correct answer here, of course, is venous return. So this is the exception. So again, when you have an increased CVP or right atrial pressure, you have a decrease in the pressure gradient that will drive the flow of the blood back to the heart. So you have a decrease in the venous return. So here's the next question. Which of the following factors tend to decrease the rate of blood flow? So you have here 4 choices. So you have anemia, vasodilation, the pressure gradient, and an increase in the vasomotor tone. So this is the Pissel's law or Puswa law. Okay, so this is determined actually, so it's actually also based in Ohm's law. So here you have the Ohm's law, and the factors affecting the resistance, of course, you have the radius. It's indirectly related to the radius of the vessel, the viscosity of the blood, and of course the length of the tube. Okay, so changes in the resistance brought about by these factors will affect now the blood flow. So rearranging this equation, so you have now the Pissel's law. law. So it is the blood flow is directly related to the pressure difference between the blood vessels from one end to the other end, rather. And then you have the radius of the vessel, and it's indirectly related to the length of the tube as well as the viscosity of the blood. So which of the following factors tend to decrease the rate of blood flow? So again, based on Picell's law, the rate of blood flow is directly related to the pressure difference and the radius of the vessel, and indirectly related to the viscosity and the length of the tube. Okay, so the first option is severe anemia. So in severe anemia, you actually have a decreased viscosity of the blood. So therefore, it will increase the rate of blood flow. So the second one, vasodilation, will increase the radius of the vessel. Of course, increased radius will increase the rate of blood flow. Letter C, increased pressure difference. So same thing, it's blood flow is directly related to the pressure difference. So when you have an increased pressure gradient, you also increase the rate of blood flow. So the last option, increase vasomotor tone. So this is vasoconstriction. You actually decrease the radius of the blood vessel, and therefore you decrease the rate of blood flow. So the correct answer here, of course, is letter D. So vasoconstriction will decrease the radius of the vessel, and therefore it will decrease the rate of blood flow. So here, increased pressure within the carotid sinus causes all of the following except. Okay, so in carotid sinus, of course, you have the baroreceptors. So these are the high pressure receptors found in the arterial system. Okay, so what will be the exception here? So all of this would be the effects of the carotid, increased pressure in the carotid sinus except. Okay, so let us just review the baroreceptors. So the baroreceptors are actually found here in the bifurcation of the common carotid, so near the carotid body. So this is the carotid sinus, so in this part, near the bifurcation. And you also have high pressure baroreceptors in the aortic arch. So these are the aortic arch baroreceptors, so as you can see here. Okay, so these baroreceptors are stretch receptors, so they are stimulated whenever there is an increased blood pressure or increased arterial pressure. So once you have an increase in arterial pressure, there will be increased firing of these baroreceptors, and they will now send signals to the brain. In the medulla particularly, and they will inhibit the activity of the cardiovascular control center. So there will be a decrease in the sympathetic outflow. So normally they inhibit the sympathetic nervous system if these baroreceptors will be stimulated. So this figure shows the effects of the increased activity in the carotid and aortic baroreceptors. So as what we have said earlier, the stimulus will be an increase in the arterial pressure. So an increase in the baroreceptor firing will send now signals to the cardiovascular control center, and will now stimulate the activity of the parasympathetic neurons, while at the same time inhibiting the activity of the sympathetic neurons. Okay, so when you have an increased parasympathetic activity, its effect is mainly found in your SA node and AV node, and it will decrease the heart rate. At the same time, because of the decreased sympathetic activity, apart from a decrease in the heart rate, there will be a decrease in the force of contraction. So we know that sympathetic fibers also end in your ventricular muscle. So with a decreased sympathetic activity, there will be decreased force of contraction apart from a decrease in heart rate. And at the same time, it will cause now a decrease in the vasomotor tone. So normally your sympathetic fibers will increase the vasomotor tone and promote vasoconstriction. But because of decreased sympathetic activity, you have actually dilation of these blood vessels. Okay? Now, the opposite is true. When you have a decrease in the blood pressure, so decreased blood pressure will decrease now the firing of the baroreceptors, and there will be now loss of the inhibitory signals in your sympathetic fibers and loss of excitatory signals to your parasympathetic nervous system. So the opposite is true when you have a decrease in the firing of the baroreceptors. There will be increased sympathetic activity. So there will be an increase in heart rate, increased force of contraction, and it will also promote vasoconstriction. Okay, so this is what I have mentioned earlier. When you have an increase in the blood pressure, the net effect now will be increased firing of the baroreceptor. So you will have increased parasympathetic output while decreasing the sympathetic output. So you have now a decrease in the heart rate, decreased force of contraction brought about by inhibitory signals to your sympathetic fibers, and also vasodilation, which will promote a decrease in peripheral resistance, whereas a decreased force of contraction and decreased heart rate in the heart will decrease the cardiac output. So this will now decrease your arterial pressure. Okay, so this will exert now a negative feedback. So at this point, when you have a decrease in blood pressure, you will have decreased firing of the baroreceptors. Okay, so going back to the question, increased pressure within the carotid sinus causes all of the following except. So as what we have said earlier, increased carotid baroreceptor firing will result in inhibition of sympathetic outflow. Okay, so in this case, you have so option A is correct. So a decrease in the sympathetic tone to the arterioles. Second, it will cause a decrease in aortic pressure. Third, of course, because of inhibitory signals, again, there will be a decrease in the vasomotor tone. So therefore, you have vasodilation. And lastly, so this will be the actual answer because inhibitory signals to your sympathetic nervous system will result in a decrease in heart rate. So the correct answer here, which is the exception, is of course letter D, atrial tachycardia, because with increased baroreceptor firing, you will actually see a decrease in heart rate. So the answer again is letter D, atrial tachycardia. So the next question here, the SA node is the pacemaker for the heart because the SA node. So you have here 4 options. Okay, so let us just review the SA node. So here you have the resting membrane potential of the cardiac tissue. So you have here the SA node, the atrial muscle, the AV node, the Purkinje fibers, and the ventricular muscle. So as you can see here, the resting membrane potential is less negative in your SA node. So since it's less negative, it's actually closer to the firing threshold, and the SA node can easily reach this threshold and therefore fire an action potential. Okay, so again, why is it that the SA node has the less negative resting membrane potential? So let's just go back to the action potential of the SA node, AV node, and the contractile muscles. So again, for the SA node and AV node, the action potential, you have 3 phases only. You have phase 4, 0, and 3, whereas in the atrial and ventricular muscle, you have the phase 4, 0, 1, 2, 3. So both in the atrial and ventricular muscle. Now the phase 4 in the SA node and AV node is actually not a true resting membrane potential because there's a slow rise in the depolarization in the voltage, mainly because of the opening of the funny sodium channels when you reach a certain voltage. So opening of funny sodium channels present in the SA node and AV node only will permit influx of sodium and will result in slow depolarization. So with a slow depolarization, it becomes less negative, the resting membrane potential, and therefore closer to the firing threshold. So this will now, when you reach the threshold, then you will have an immediate firing of an action potential in both the SA node and AV node. So comparing the resting membrane potential of the AV node and the SA node, so your SA node is actually less negative. So again, it's closer to firing, much closer to the firing threshold. and therefore there will be spontaneous depolarization, leading to generation of action potential. So the fast discharge now, so you have more action potentials now, will override the potentials, generation of action potentials in the AV node and the Purkinje fibers as well as the contractile muscles. So going back to the question, the SA node is the pacemaker for the heart, so meaning it dictates the rate by which the heart will contract. So you have here the four options. So the first one, is it the most richly innervated structure in the heart? So this is incorrect. Second, it is the only structure in the heart capable of generating action potentials. Again, this is incorrect. So we already know that all the muscle cells in the heart are capable of generating action potentials. But since the SA node has the highest rate of automatic discharge, it can actually override the capability of the other muscle cells in generating action potential. Okay, so again, why is it? Why does it have the highest rate of automatic discharge? So because of less negative resting membrane potential, it can easily reach the firing threshold. So therefore, it can you can actually have increased number of action potentials that can be generated in the SA node. Okay, so letter D is also incorrect because as what we have said earlier, the phase 4, which is the resting membrane potential for the SA node, it's actually there is actually a slow depolarization in phase 4 because of the opening of the Fanny sodium channels. So the correct answer here, of course, will be letter C. So SA node is considered the pacemaker because it has the highest rate of automatic discharge owing to the less negative resting membrane potential. Okay, so moving on to the next question. So if a drug is given that acts specifically to increase myocardial contractility, so you have here the four choices. So when you say a drug that increases myocardial contractility, it means that it increases the inotropic state of the heart. Okay, let's go back to the pressure volume loop in your left ventricle. So again, you have here the volume and you have here the pressure in the left ventricle. Okay, now when you have an increase in the inotropic state of the heart, so what will happen? There will be an increase in the pressure, maximal systolic pressure that can be generated in the ventricles. Okay, so as you can see here, this is the maximal systolic pressure. But when you have an increase in inotropic state, so this is the maximal pressure that can be generated. So when you have a greater pressure that can be generated in the ventricular wall, therefore there will be a greater force of contraction. So as you can see here, the stroke volume will, from here, it will actually increase. Okay, so you have an increase in stroke volume and systolic volume will therefore decrease. Okay, now as you increase the stroke volume, of course, you increase the cardiac output because cardiac output is equal to an increase in stroke volume times the heart rate. So this is again the Frank-Starling curve or the cardiac output curve. Okay, so you have here the curve when you have a normal inotropic state, but when you increase the inotropic state, there will actually be a shift upward of your cardiac output curve. Okay, so meaning at the same left ventricular and diastolic pressure, so this is, let's say this is the diastolic pressure. When you have an increase in the inotropic state, of course, because of the upward shift, so you have this one. So the stroke volume will increase. So here in a normal contractile state, this will be at the same right atrial pressure. This will be the stroke volume. But when you have an increase inotropic state, the stroke volume will increase. So what about vascular function curve? So the earlier slide, it is the cardiac output curve, but this time this is the vascular function curve. So the vascular function curve shows the dependence of your right atrial pressure from your cardiac output. So as you can see, there is an inverse relationship. When you increase the cardiac output, there is a corresponding reduction in your right atrial pressure or your central venous pressure. Okay, so why is there an inverse relationship? So here, as you can see here, this is the arterial system, and here you have the venous system, and of course you have here the heart. Okay, so when you increase the cardiac output, what will happen? Of course, you will increase the arterial pressure. So remember, BP is equal to cardiac output times TPR. So when you increase your cardiac output, you will increase the arterial pressure. Okay, so this will likewise, of course, increase the pressure in your microcirculation, particularly your capillaries. Okay. However, with an increase in the arterial pressure, there will actually be vasoconstriction. So why? If you remember autoregulation, whenever there's an increase in the arterial pressure, the smooth muscle of the blood vessels, particularly your arterioles, will constrict. So in this case, it will now, an increase in the cardiac output, an increase in the arterial pressure will now increase the arteriolar resistance, mainly again because of the contraction of the smooth muscles of the arterioles brought about by autoregulation or myogenic regulation. Okay, so what will happen now? So there will be a decrease in the blood flowing back into the venous system. So a decreased blood flowing into the venous system will of course decrease the peripheral venous pressure and therefore your central venous pressure and your right atrial pressure. Okay, so that will explain the inverse relationship between the cardiac output and the right atrial pressure. So again, when you increase the cardiac output, you decrease the right atrial pressure. Okay, so to bring back the equilibrium between the cardiac output and the venous return. Okay, so going back to the question, so if you give an inotropic drug, which will increase the myocardial contractility, so what will happen now? So for the first option, the mean arterial pressure will decrease. Okay, so we have already mentioned earlier, when you give an inotropic drug, it will actually increase the stroke volume. So this is already incorrect. Okay, so it will increase the stroke volume and will likewise increase the arterial pressure. So again, when you have an increase in the stroke volume, you increase the cardiac output and therefore you increase the arterial pressure. Okay, so since this is decreased, so this is also incorrect. Okay, so we have two options left. You have option B and option D. So option B, capillary blood flow will decrease. So as what we have said, an increase in the arterial pressure will increase the capillary hydrostatic pressure, which will also increase the flow of the blood into the capillary. Okay, so again, this is incorrect. So the correct answer here will be letter D. So the central venous pressure will decrease. So as I've said earlier, there's an inverse relationship between the cardiac output and the central venous pressure or the right atrial pressure. So if you increase the cardiac output, there will be an increase in the arterial pressure, which will cause now an increase in arteriolar resistance, which will decrease the venous pressure. So decreased peripheral venous pressure will likewise decrease the central venous pressure and the right atrial pressure. So moving on to the next question, a sudden hemorrhage will cause, so you have here the changes. So let's try to answer this one. So with the hemorrhage, there is a decrease in intravascular volume, which will decrease the filling pressure. So a decrease in filling pressure will decrease the venous return and therefore decrease right atrial pressure. So you decrease now the preload. So you have now a decrease in stroke volume and cardiac output. Okay. So as you can see here, the mean systemic filling pressure is actually dependent on the volume in the vascular compartment. Okay, so here, let us now discuss the mean systemic or mean circulatory filling pressure. So the mean systemic filling pressure, the mean circulatory filling pressure is the equilibrium pressure in the circulatory system in the absence of blood flow. So meaning this is the pressure that occurs in the circulatory system after a stop in cardiac output and redistribution of blood, so that all the pressures are the same throughout the system. So when the cardiac output is zero, the blood will be redistributed from the arterial system into the venous system. So the arterial pressure will fall, whereas your venous pressure will rise. So when there is now, when the pressures are now equal, this is what you call now the mean circulatory filling pressure. There will be no more blood flow. Okay. So as you can see here, this is also the pressure that pushes the venous blood from the periphery towards the heart. So why? So since the veins are distensible and contain most of the blood, they comprise most of the vascular compliance. So therefore, the mean circulatory filling pressure provides an estimate of the distending pressure in the small veins and venules. Okay, so here, if you look at this equation, so this is the venous return. So it's equal to the pressure in the peripheral veins as determined by the mean circulatory or mean systemic filling pressure. So as I've said, the mean circulatory filling pressure is related to the fullness of the circulatory system. And since the veins comprise most of the compliance because of its distensibility, it provides an estimate of the mean circulatory or mean systemic filling pressure. So this is actually the pressure in your peripheral veins. Okay, so the pressure gradient will be therefore from the peripheral veins, and the downstream end of the pressure gradient is of course the pressure in the right atrium. Okay, so the difference between the mean systemic filling pressure and right atrial pressure will determine the venous return. So if you increase the pressure gradient, okay, you now increase the venous return. So thus, when you increase the mean circulatory filling pressure, you increase the venous return. So on the other hand, when you decrease the filling pressure, you decrease the venous return. Okay, so as I've said earlier, blood volume is one of the factors that will determine the filling pressure. The other one is the vascular or the venous capacitance. Okay, so let's discuss these two factors. So again, the two factors that affect your mean circulatory filling pressure, you have the blood volume and the vascular capacity. So when you have an increase in blood volume, there is an increase in the mean circulatory filling pressure. So why? So when you have an increase in blood volume, there will be larger amount of blood in the venous system. So again, mainly because the veins are very distensible. And with an increased volume of blood in the veins, therefore you increase the mean circulatory filling pressure. So as you can see here, the normal mean circulatory filling pressure is about 7 millimeter mercury. But when you have an increase in the blood volume in this vascular function curve, there will be an upward shift or rightward shift of the curve. Okay, so at the same right atrial pressure, when you have an increase in blood volume, so let's say this is the normal curve, at 2 millimeter mercury right atrial pressure, the venous return is only 5. But when you have an increase in the mean systemic filling pressure, at the same right atrial pressure of 2 millimeter mercury, so here, your venous return now will be 7 liters per minute. Okay. Now the opposite is true. When you have a decrease in blood volume, you have decreased amount of blood in the venous system. Therefore, it will decrease the mean circulatory filling pressure. So at the same right atrial pressure from 5, the venous return now will only about 3 liters per minute. Okay. So the second factor is the vascular capacitance. So here in this case, the vascular capacitance is actually determined by the venomotor tone. Okay? So when you have venoconstriction, meaning you have an increase in the venomotor tone, what will happen since the veins are constricted? There will be a decrease in the venous capacity. So with a decrease in venous capacity, there will be a corresponding increase in the mean circulatory filling pressure. Okay, so remember the veins are closed, so there will be an increase in pressure in the peripheral veins. Okay, so the same thing when you have decreased venous capacity, what will happen now? So you will have an upward shift of the curve. So here, again, from 7, you will have 9 millimeter mercury mean systemic filling pressure. Okay? So again, because the veins are constricted, you have an increase in the filling pressure. So the same thing, when your right atrial pressure is 2 because of the increase in the mean filling pressure brought about by the increased venomotor tone. So you have now 7 liters per minute. From 5 liters, it becomes 7 liters per minute. On the other hand, when you have venodilation, so meaning there's decrease decreased venomotor tone, and therefore there's increased venous capacitance. So from 5 liters per minute, the venous return now will become 3 liters per minute at the same right atrial pressure of 2 millimeter mercury. Okay, so mean circulatory filling pressure is synonymous with mean systemic filling pressure. So when you say circulatory filling pressure, this includes the pulmonary pressure. Okay, but since the pulmonary pressure is very small, we can use the two terms interchangeably: the mean circulatory filling pressure and mean systemic filling pressure. Okay. So going back to the question, a sudden hemorrhage will cause. So here you have the different choices. So decrease stroke volume, the first option, decrease stroke volume, decrease central venous pressure. So this is actually the correct answer, okay? So a sudden hemorrhage will cause a decrease in the stroke volume because there will be a decrease in the mean systemic filling pressure. So again, hemorrhage will decrease the intravascular volume, and the decrease in the blood volume will decrease the mean filling pressure. And since the filling pressure determines the venous return, when you have a decrease in the mean circulatory filling pressure, you decrease the venous return. Okay, so remember this: the filling pressure represents the pressure in the venous system. So when you have a decrease in the pressure in the venous system, there will be a decrease in the gradient that will drive the flow of blood back to the heart. So this will decrease the venous return, decreasing the right atrial pressure. And when you decrease the right atrial pressure, of course, you decrease the preload, you decrease the stroke volume, and of course, decrease the cardiac output. Okay, so the decrease in the venous return, of course, will likewise decrease the central venous pressure and decrease in the right atrial pressure. That will now decrease the preload and your stroke volume. Okay, so all the other options are incorrect. So here you have increased stroke volume. This is incorrect because the CVP is increased. So when you have decreased venous return, again, you have a decrease in the central venous pressure. Okay, so here again, same thing, you have an increase in CVP. So all the three other options are incorrect. So the correct answer will be letter A. So moving on to the next question, the Frank-Starling relation is essentially a restatement of. So we have been discussing the Frank-Starling law. So again, let me show you this curve. So as you increase the preload brought about by the increase in the end diastolic volume secondary to an increase in right atrial pressure, there will be an increase in the active tension in the ventricles. Okay, so this will lead to a more forceful contraction. Okay, so why is it that you have a greater active tension when you have an optimal length of the myocardial fibers? So this can be explained in this figure. Okay, so here at very short length of the myocardial fibers, in this case, the actin filaments will overlap. Okay, so when you have overlap of the actin filaments, of course, there will be less binding sites for myosin, and this will, of course, decrease the number of cross bridges. At normal resting length, so here you have now, you have actually formation of cross bridges already, but still, because you do not have room for actual shortening of the muscle, the active tension that can be generated in the ventricular wall is still smaller compared when you have the optimal sarcomere length. Okay, so here you have now both optimal number of cross bridges. At the same time, you have room for shortening. Okay, so you can have now a greater active tension generated when you have optimal length of the myocardial fibers, again as determined by the end diastolic volume. Okay, now Frank-Starling law, of course, there's a physiologic limit. So you increase the end, as you increase the end diastolic volume, or as you increase your preload, you increase the stroke volume within physiological limit. Okay, so why? Because beyond the optimal length, so as you can see here, there will now be a reduction in the active tension. So why? So this is because when you overstretch the myocardial fibers, as you can see, you have now less overlap between the actin and the myosin filament. Okay, so if you overstretch the myocardial fibers, so meaning there will be less number of cross bridges that can be formed, and therefore the active tension will be reduced. Okay. So going back to the question, so therefore the Frank-Starling relation is essentially a restatement of the letter D, the length tension diagram. So as you increase the myocardial fiber length, you increase the active tension that can be generated in the ventricular muscle. Okay, so it is not the Purcell's law. So there's no Purcell's law of the heart. Okay, so this is mainly in the blood vessel. So Laplace law of the heart is likewise different. So this is the variables here are mainly the pressures in the ventricular wall, and of course your tension generated within the ventricular wall. Okay. Now, it is also not the force velocity relationship of the cardiac muscle. So, just like in your skeletal muscle, you also have a force velocity relationship, but this is more an effect of the afterload. So it's not really the preload. So Frank-Starling is the variable is mainly your preload, which will determine the myocardial fiber, and this will determine the active tension. Okay, so we go on to we move to the next question. So next question. So the force of cardiac contraction is enhanced by, so you have here several factors. Okay, so let's go to the next slide. So here, let's discuss the excitation, contraction, coupling in cardiac muscle. Okay, so when an impulse, electrical impulse, that originates, of course, from your SA node, when it reaches the muscle, the atrial and the ventricular muscle, particularly your ventricular muscle, it will now cause the depolarization to spread down to your T tubules. Okay, now remember that you have the 5 phases of action potential in both the atrial and ventricular muscle. So you have the phase 4, which is the true resting membrane potential. But when an impulse reaches the cardiac muscle, you have now the opening of the fast sodium channel. So this is the phase 1. Okay. Now, eventually, this will be followed by phase 2 when you have the transient opening of the potassium channels. And soon after that, you will have the slow opening of your calcium channel. So these are the slow calcium channels, and this is now the phase 2, which corresponds to the plateau of the action potential. So why is there a plateau? So as the potassium goes out, the calcium goes into the cell. So therefore, the membrane voltage will remain the same. Okay, so you have the exit of potassium, the entry of calcium. So the membrane voltage stays the same. So therefore, you have the plateau of the action potential. Okay. So the calcium, these calcium channels are actually your DHPR channels. Okay. So these are the DHPR channels. So here, this permits the entry of calcium, which will then this DHPR will then now cause the opening of the calcium release channels from your sarcoplasmic reticulum. So these are your RYR channels. So these are calcium release channels. So this phenomenon is what we call the CICR, calcium-induced calcium release. So this is only this is found in the cardiac muscle and not in the skeletal muscle. So again, during the phase 2 of the action potential, you have the opening of the DHPR, which will permit the entry of the calcium into the cell. Okay, so this will now result into the opening of the RYR channels of the sarcoplasmic reticulum, which will permit now the calcium release from the sarcoplasmic reticulum. So it's this part. Okay, so you have now an increase in the intracellular or cytoplasmic calcium, which will now bind to your troponin C in your actin filament. So this is your actin filament. So you have here the troponin. So calcium will bind to your troponin, which will cause the movement of the tropomyosin. Okay, so when you have the movement of the tropomyosin, then you have now the exposure of the binding site sites for myosin in your actin filament. Okay, so you have now the binding of the actin and the myosin. So you have the formation of the cross bridges, and then you have, of course, the power stroke, and thereafter, after the contraction, you have now the release of your calcium from your troponin C. Okay, so this calcium now will go back to your sarcoplasmic reticulum. However, this is an active process requiring ATP. So this is your SERCA. Okay, so SERCA is normally inhibited by your phospholamban. Okay, so if the phospholamban becomes phosphorylated, there will be loss of inhibition of this SERCA, and this will increase now the reuptake of the calcium from your cytoplasm back into the sarcoplasmic reticulum. Okay, so usually your phospholamban is phosphorylated when you have an increase in the cyclic AMP. Okay, so again, phospholamban normally inhibits your SERCA, but when it becomes phosphorylated, there will be loss of this inhibition, resulting in increased calcium reuptake. Okay, so the increase in the calcium reuptake will now increase the calcium turnover. So such that when you have increased cyclic AMP, there is actually an increase in the calcium turnover, mainly because of the phosphorylation of your phospholamban with loss of inhibition of SERCA. Okay, so let's just review the differences between the skeletal and the cardiac muscle. Okay, so structure-wise, of course, the cardiac muscle fibers are branched and interconnected with intercalated disc. Okay, so this intercalated disc contain gap junctions that permits the spread now of electrical impulse. So you have impulse coming from SA node down to both atria, ventricles, including your AV node. Okay, so thus the muscle now forms a functional system wherein stimulation of one area results in contraction of the whole muscle. So again, this is because one of the property of the cardiac muscle is its ability to generate their own action potential, which is also termed as automaticity. Okay, so it is not, therefore, the cardiac muscle is not dependent on the neural stimulus to initiate contraction. Unlike in your skeletal muscle, where each individual muscle cell are stimulated by neurons. So remember, you have the neurons in the neuromuscular junction. So when you have an increased activity in the presynaptic neuron, in the neuromuscular junction, it will eventually cause depolarization in the postsynaptic area. Eventually, it will initiate contraction in the skeletal muscle. Okay, so in the cardiac muscle, you don't need exactly a neural stimulus to initiate contraction. Okay, however, you still have innervation, of course, in the heart, and this is mainly your autonomic nervous system. So the ANS does not initiate contraction, but it modulates the cardiac function. So both the rate of contraction and the force of contraction. Okay. Another thing, unlike in skeletal muscle, wherein you only have the opening of the sodium channels that will cause depolarization, in the cardiac muscle, you have the opening of both the sodium and calcium channels. Okay, so during the depolarization process, so in the contractile muscle, so this will be the opening of the fast sodium channels in phase 0 and the opening of the slow calcium channels in phase 2. Okay, so because of the calcium and influx during the plateau phase or phase 2, of course, you will have the calcium-induced calcium release. Again, this is absent in skeletal muscles. Okay, now this plateau will also lead to longer duration of action potential in your cardiac muscle. So this will result in longer refractory period, particularly longer absolute or absolute refractory period or effective refractory period, so ARP or ERP. And this is very important because when you have longer absolute refractory period, it will prevent the tetanic contraction of the muscle. Okay, of course, when you have tetanic contraction of the muscle, there will be a decrease in the ventricular filling time, and therefore there will be a decrease in the preload, decreasing the tension in the wall, and therefore decreasing the force of contraction. So you do not want sustained tetanic contraction in the cardiac muscle. So that's why you have the plateau phase of the action potential. Okay, so moving on to the next slide. So apart from circular uptake of calcium, so remember you have influx of calcium coming from the ECF during the phase 2 of the action potential. So this calcium must again be extruded out of the cardiac muscle cells. So there are two ways. So the ECF calcium will be released back into the ECF by first you have the AT-dependent calcium pump. Okay, so this is the calcium ATP. So again, active transport requiring ATP. Okay, so these are the you have here your calcium pump. Okay, now another one you have the sodium calcium exchanger. So for every 3 ions of sodium in the ACF, it will be exchanged with 1 calcium of ion. So 3 sodium in, 3 ions of sodium going inside the cell, and 1 ion of calcium going out. Okay, so the gradient that will permit the exchange between sodium and calcium is provided by your sodium potassium pump. Okay, so remember after the during the depolarization, you have the entry of sodium, and during repolarization, you have the exit of potassium. Okay, so the one that will bring it back to its own compartment, so meaning the sodium will be extruded out, and the potassium will go back to again inside the cell. Will be this will be the activity of the sodium potassium pump. So again, this is after the action potential. So the sodium will go out again, and the potassium will go in. Okay, so therefore as you have when you have the activity of the sodium potassium pump, the sodium is now back in the ECF. Okay, so this will now provide the gradient for the exchange between the sodium and calcium. So when the sodium is already outside the cell, then the sodium can be used in exchange for calcium ions. Okay. Now, what will happen when you have inhibition of the sodium potassium ATP? So, for example, when you give a patient with an inotropic drug, so this is digitalis or digoxin or cardiac glycoside. So the main or the mechanism of action of this drug is that it inhibits sodium potassium ATPase. Okay, so after the action potential, so supposedly with a sodium potassium pump, the sodium will be extruded out and the potassium will go in. However, because of the inhibition of the sodium potassium ATPase, so the sodium now remains inside the cell. Okay, so you have an increase in intracellular sodium. So meaning there will be no gradient for the exchange between the sodium and calcium ions because your sodium is inside the cell. So therefore, because there is no gradient that will drive it back to the calcium out of the cell, your calcium will remain inside the cell. Okay, so again, when you have an increased cytosolic calcium, it's capable of binding with your troponin C. So you have now formation of more cross bridges. So therefore, it increases the inotropic state of the heart. So earlier I mentioned that the heart is not really dependent on the nervous system to initiate contraction. However, the autonomic nervous system, particularly your sympathetic nervous system, actually will modulate the function of the heart. Okay, so not only the rate of contraction, but also the force of contraction. Okay, so the sympathetic nerve, as you can see here in this particular slide, in this figure, it will now release neurotransmitter norepinephrine in the ventricular muscle. Okay, so this norepinephrine now will bind to your beta receptors, okay, particularly your beta 1 receptors, and as soon as it binds to the receptors, it will activate the GS protein, which will activate your adenylate cyclase, and you have now the release of cyclic AMP, which will activate your protein kinase A. So your pKa now will open the calcium channels, permitting entry of calcium into the cell. Okay, so you have an increase in intracellular calcium. Another thing is that I remember I also mentioned I also mentioned earlier that your cyclic AMP will eventually phosphorylate your phospholamban. And this phospholamban, when phosphorylated, there will be loss of inhibition of the circa. So therefore, your uh, cyclic AMP now will facilitate the reuptake of calcium into your sarcoplasmic reticulum. So the increased reuptake will facilitate increased calcium turnover. Okay, so the increased entry of calcium into the cytoplasm via the opened calcium channels plus the increased calcium turnover will increase now the formation of cross bridges. Therefore, it will increase the contraction. Okay. Now, what will happen if you block the receptor? So let's say you give a drug that will bind to the beta receptor. So you have now inhibition of the sympathetic nervous system. So meaning that neurotransmitter cannot anymore bind to the beta receptors. So therefore, this will decrease the cyclic AMP and the protein kinase A activation. So you have now a decreased opening of the calcium channels. So you have decreased opening of the calcium channels plus decreased calcium turnover. So therefore, there will be a decrease in the cytosolic calcium. So you have a decreased formation of cross bridges. So we can now answer this question. So the force of cardiac contraction is enhanced by. So you have here the first option, a reduction in preload. So this is incorrect because we know that it is actually an increase in preload that will increase the force of contraction, okay, based on Frank-Starling law. Now, second option, an increase in interstitial fluid sodium. So meaning you provide a gradient for the exchange between the sodium and calcium, okay? So the sodium will go in and the calcium will be extruded out. So when the calcium goes out of the cell, therefore there will be a decrease in the cytosolic calcium and therefore decrease formation of cross bridges. So you wanted an increase in the cytosolic calcium to increase the formation of cross bridges. Okay, so you only have two options left. So you have option C and option B. Now in option B, administration of a beta blocker, so as what I have mentioned earlier, will decrease the cyclic AMP release and decreasing the protein kinase A activation. So therefore, there will be decreased opening of the calcium channels and decreased activity of circa. Okay, so what will happen? You will have a decreased cytosolic concentration of calcium and the decrease in the calcium concentration in the cytoplasm. Okay, so the option left here, of course, would be letter C. So this is the correct answer. When you have inhibition of the sodium-potassium ATPase, so the sodium, so after the action potential, the sodium is not excluded out of the cell. So it remains inside the cell. Since the sodium is inside the cell, therefore, there is no gradient for the exchange of the sodium and calcium. So your calcium will also stay inside the cell, and therefore, it is capable again of binding with your troponin C, and this will result in increased formation of cross bridges, and therefore, you have an increased force of cardiac contraction. So this is the correct answer. So moving on to the next question. So the following statements about the preload are true except, okay? So you have here the four choices. So related to the end diastolic volume, the right atrial pressure, the venous return, and the pulmonary artery pressure. Okay, so again, what is preload? So this is the length of the muscle at the onset of contraction. So this is determined by the end diastolic volume, and the end diastolic volume is of course determined by your right atrial pressure. Okay? So when you have an increased right atrial pressure, there will be an increased pressure gradient between the right atrium and the right ventricle. So an increase in the right atrial pressure will therefore increase the velocity of blood flow because of this increased pressure gradient, and will increase now the end diastolic volume because of the increased ventricular filling. Okay, so this increase in end diastolic volume and pressure will increase now the length of the myocardial fibers at the onset of contraction. And again, as you increase this preload, therefore you increase the force of contraction, you increase the stroke volume. So here are the factors affecting your preload. So as what I have said earlier, it's actually an increase in the central venous pressure or right atrial pressure that will determine the flow of blood from the atrium down to the ventricle, and therefore it will increase the ventricular filling and preload. Okay. Now this right atrial pressure or CVP is of course dependent on the venous return, and the venous return is determined by the mean systemic filling pressure, and these factors actually affect the filling pressure. So you have here the blood volume, of course, and the venous capacitance. Okay. Now, apart from the right atrial pressure, you have here the other factors. That will determine your preload. Okay, so of course, when you have a decrease in the heart rate, there's more time for the ventricular filling. So you have now an increase in the preload. Okay, when the ventricles are very compliant, likewise, it will increase the amount of blood in the ventricles. And when you have atrial contraction, so it will push more blood. So a more forceful atrial contraction will push more blood into the ventricles. So it will again increase the end diastolic volume and therefore your preload. Okay. So here you have an increase in aortic pressure. So as you can see, the increase in aortic pressure will also increase the preload. Okay. So why? So supposedly this is an afterload, correct? So when during the period of systole or ventricular contraction, when you have an increased aortic pressure, it will be more difficult to pump the blood into the aorta. So you have a decrease in the stroke volume. Okay, so increased afterload will actually decrease the stroke volume, and therefore your end systolic volume will increase. So your end systolic volume will increase, and then during the period of diastole, you have again blood coming from the atrium. Therefore, together with the remaining blood during right after systole, plus the incoming blood from the atria, it will now increase your preload. Okay. But again, as I've said, an increase in aortic pressure is an afterload. So during systole, this will be a problem because you will have a resistance to the ejection of the blood, decreasing the stroke volume and again increasing the end systolic volume, which will eventually, during diastole, increase the ventricular filling and at the onset of contraction, therefore, you have an increase in the amount of volume. So going back to the question now, the following statements about the preload are true exact. So you have here 4 options. So number 1, it is equivalent to end diastolic volume. Okay, so this is correct because your end diastolic volume will determine the stretch of the myocardial fibers at the onset of contraction. So which is essentially your preload. Okay, now it is related to right atrial pressure. So your right atrial pressure will increase the end diastolic volume. And your right atrial pressure is actually dependent on your venous return. Okay, so an increase in the venous return will increase the right atrial pressure, which will increase ventricular filling. Therefore, it will increase the end diastolic volume. Okay, so the exception here in this particular question is, of course, D. So the preload is the length of the myocardial fiber at the onset of contraction. So it is not synonymous to the pulmonary arterial pressure. Okay, so your right ventricular pressure actually during the period of systole must be greater than the pulmonary arterial pressure to be able to open the pulmonic valve and to push the blood into your pulmonary artery. Okay, so the normal right ventricular pressure is about 1/5 of the left ventricular pressure. So if your left ventricular pressure is 120 to 125, your right ventricular pressure is just 25. Okay, but the pulmonary artery pressure on the average is only about 14. Okay, so during the period, so this occurs during the period of systole, your right ventricular pressure will go as high as 25, and with the gradient now, coming from the between the right ventricle and the pulmonary artery. So from 25 to 14, it will open the pulmonic valve and will push the blood into the pulmonary circulation via the pulmonary artery. Okay, but again, when the ventricles relax, the right ventricular pressure, same thing with the left ventricular pressure, it will go down to zero. So if you remember the pressure in the ventricle, you have a numerator and a denominator. So the numerator responds to the systolic pressure, whereas the denominator responds to the diastolic pressure in both ventricles. So moving on to the next question, a person was accidentally stabbed on the neck, resulting to massive bleeding. So these are the expected compensatory responses from the cardiovascular system. Okay, so you have changes in the following cardiovascular parameters. So here again, this is a concept map of the events that occur when you have hemorrhage. So again, decrease intravascular volume brought about by hemorrhage will decrease your venous return brought about by the decrease in the filling pressure. So this will eventually decrease your cardiac output, decreasing your arterial pressure. Okay, so because of the decrease in pressure in the arterial system, there will be decreased baroreceptor firing with loss of inhibition of the sympathetic nervous system. So you have now an increase in the sympathetic outflow. Okay, so the effects now will be seen in both the heart and the vascular system. So in the heart, there will be an increase in the cardiac output because of the increased heart rate and increased force of contraction brought about by the increased sympathetic activity. Now, in the vascular system, it will promote both arteriolar and venoconstriction. Okay, so in when you have arteriolar constriction, of course, it will increase the total peripheral resistance, which will decrease now the capillary pressure and promote fluid reabsorption. Now, at the same time, because of the vasoconstriction, there will be also a decrease in the GFR, which will decrease now. Of course, when you have a decreased GFR, there will be a decrease in the sodium and water excretion. Okay. So, however, the decrease in GFR will actually activate your RAAS. So, with the activation of the RAAS, it will likewise increase the volume in the vascular compartment, mainly because the aldosterone secreted when you have activation of the RAAS will promote now sodium reabsorption, and of course sodium will be followed by water. So all of these factors will now increase the circulating volume. Okay. Now, in venoconstriction, you actually mobilize now the blood reservoir. So it will, you have additional blood now in the venous system that will go back to the heart. So there is an increase in the venous return. Plus, with increased venomotor tone, of course, there will be an increase in the filling pressure. And we already know that with an increased filling pressure, there will be an increase in the venous return because it pushes the blood back to the heart. So if we go back to the question, so a person was accidentally stabbed on the neck, resulting to massive bleeding. So the following are expected compensatory responses from the cardiovascular system. Okay, so you have here the 4 options. So of course, when you have hemorrhage, this will decrease the cardiac output, decrease venous return, decrease cardiac output, which will decrease the arterial pressure, therefore decrease baroreceptor firing and increase now sympathetic activity because of the loss of inhibition coming from the baroreceptors. Okay, so this will lead to arteriolar constriction. So the option A is already incorrect because with arteriolar constriction, you have an increase in the total peripheral resistance. Okay, so as I've said, so this one, the constriction of arterioles is expected, unexpected compensatory response from the cardiovascular system. So the correct answer here will be letter B. Okay. So what about option C and option D? So again, with the sympathetic activity, you actually have venoconstriction. And letter C is likewise incorrect. in the renal system, the activation of RAS brought about by decreased GFR will actually facilitate sodium reabsorption because of the secretion of aldosterone. So again here, um, you have the option B as the correct answer with an increased sympathetic outflow as a compensatory response. You have vasoconstriction in the both in the arterial and the venous system. Okay, so we have here the next question. So in patients with heart failure, all of the following are true except. So you have here four options. So let's discuss this. We go to the next slide. So again, this is the Frank-Starling curve. So here, this is the normal curve. Now, when you have a decreased contractility brought about by heart failure, so there will be a downward shift of the curve. So meaning at the same atrial pressure, you have a decrease in the force of contraction, therefore a decrease in the stroke volume. Okay. Now, because of the decrease in stroke volume, of course, you have a decrease in cardiac output, which will decrease the arterial pressure and decrease the baroreceptor firing. So, because of this, there's loss of inhibition of the sympathetic nervous system. So, you have increased SNS outflow now. So, these are the effects. You have the increased total peripheral resistance, mainly because of the arteriolar and the venoconstriction. In the heart, you have the increased force of contraction and an increase in heart rate. So this will increase now the cardiac output to correct the initial decrease in cardiac output brought about by heart failure. So these are compensatory mechanisms when you have a decrease in the cardiac output. So here's a figure showing the effects of left ventricular failure, particularly the backward effects of left ventricular failure. Okay, so when you have left ventricular failure, what will happen? You have decreased emptying of the left ventricle, and of course, the decreased emptying will cause a decrease in stroke volume, but an increase in end systolic volume. So you have here an increase in end systolic volume. Now, during the period of diastole, of course, you have additional, you have blood now from the atrium, left atrium down to the left ventricle, then and adding the increased end systolic volume. So what will happen? You actually have an increase in the preload in the left ventricle. So remember, you have an increased end systolic volume plus an increase in the and diastolic volume during ventricular filling will eventually increase the preload in the left ventricle. So this increase in the preload in left ventricle will increase the left ventricular pressure. Okay, so you have now an increased left ventricular pressure. Now, because of this increased left ventricular pressure, what will happen now during ventricular filling or during diastole? So there will be a smaller pressure gradient now between the left atrium and the left ventricle. Okay, so you have left atrial pressure now and left ventricular pressure. Because of the increased left ventricular pressure, you have decreased pressure gradient. So what will happen? You will have a decrease in the ventricular filling. Okay, so meaning there will be an increase in the volume of blood in the left atrium during systole. So when the AV valves already close here in this during the period of systole. So you have now an increase in the left atrial volume. Okay, so this will increase now, of course, with an increase in left atrial volume. This will increase the left atrial pressure. Okay, so in other words, in left ventricular failure, you have the left-sided filling pressure is increased. Okay, so with an increase in the left atrial pressure, this will likewise increase the volume in the pulmonary veins. So mainly because the forward transmission of blood is reduced from the pulmonary veins into the left atrium, again because of the increase in the preload, which will increase the left atrial pressure. Okay, so the increased left atrial pressure will likewise increase the pulmonary venous pressure. So as you can see now, there is now backward transmission. So there's passive backward transmission of blood. Okay, so there's no forward transmission, mainly because the downstream pressures are usually greater compared to the upstream pressure. So this increases the volume on the left side of the heart, and there will now be backward transmission of both the volume and pressure into the pulmonary circulation. So as what we have said, there's increased volume in the pulmonary veins, which will increase the volume of blood in also in your pulmonary capillary bed. Okay, so when you have increased volume in the pulmonary capillaries, this will increase the pulmonary capillary hydrostatic pressure. So therefore, there will be capillary filtration. So you have now fluid from the capillaries moving into the interstitium and alveoli. Okay, so this will now result in pulmonary edema. Okay, now apart from the increase in the pulmonary capillary pressure, hydrostatic pressure, this will again be transmitted back to the pulmonary artery. So you will also have an increase in the pulmonary arterial pressure. Okay? So with an increase in the pulmonary arterial pressure, so your right ventricle, there will be an increase in the afterload for your right ventricle. Okay, so eventually an increase in the pulmonary artery pressure will result in right ventricular failure because of the increased afterload to the ejection of the blood coming from the right ventricle. Okay, so there will now be an increase in the right ventricular pressure, which will be again transmitted to the right atrium, and eventually you have now your right ventricular failure. So going back to the question, so in patients with heart failure, all of the following are true except. Okay, so the first option, decreased contractility, of course, in patients with heart failure will decrease the ejection of blood, therefore it will decrease the stroke volume. Okay, now as a compensatory mechanism, the decreased stroke volume and cardiac output will decrease the arterial pressure, which will decrease now the baroreceptor firing, and with decreased baroreceptor firing, you have increased sympathetic activity that will increase heart rate to compensate and try to maintain the normal cardiac output. Okay. Now, letter C, in left ventricular failure, the fluid accumulates in the lung, leading to pulmonary congestion. So this is correct because with left ventricular failure, there will be a left-sided filling pressure is increased. So there will be backward transmission of blood from the left side into the pulmonary circulation. Eventually, the increase in the pulmonary capillary hydrostatic pressure will cause filtration of fluid out of the capillary, and therefore you have pulmonary congestion. Okay, so obviously the last option here will be the correct answer. So this will be the actual exception. Right ventricular failure leads to increased pulmonary artery pressure. So this is incorrect. Okay, so it is the opposite. So an increased pulmonary artery pressure will eventually cause right ventricular failure because with an increased pulmonary artery pressure, there will be increased afterload for your right ventricle. So with an increased afterload, therefore the right ventricle will have difficulty in ejecting the blood into the pulmonary artery. Okay, so eventually there will be a rise in the right ventricular pressure and volume, and eventually this will lead to right ventricular failure. So this is the last question. In septic shock, which of the following is true? So you have your four choices. So there are actually several types of shock. So one of them, of course, is septic shock. So let us now differentiate the different types of shock. So the cause of shock can either be a problem on the preload, contractility, or the afterload. Okay, so if you have a problem in the preload, so you have hypovolemic shock. So this is a decrease in the intravascular volume. Therefore, there will be a smaller ventricular and diastolic volume, which will decrease the preload. And of course, a decrease in preload, you have decreased generation of pressure in the heart, and therefore the blood flow. Now, in contractility, so this is cardiogenic shock. There is intrinsic abnormality of the heart. So there is decreased power of contraction. So there's inability to deliver blood into the peripheral circulation. Okay, so example would be cardiomyopathy and myocardial infarction. Okay, so what about afterload? So if the problem is in the afterload, you actually have three types. So the first one is the anaphylactic shock. So you have a release of inflammatory mediators. So for example, your histamine, which will lead to vasodilation. In neurogenic shock, there is loss of autonomic innervation. So you have relaxation of the smooth muscles of the blood vessel. Again, of course, this will cause vasodilation. So an example is when you have injury to the spinal cord. Lastly, you have the septic shock. So the toxins released by the organism will cause the release of inflammatory mediators, specifically your nitric oxide, which is a very potent vasodilator. So of course, you will have vasodilation. Okay. So in all of these three types, anaphylactic, neurogenic, and septic shock, you have vasodilation. Therefore, you have a decrease in the afterload. Okay. So this vasodilation, of course, will likewise decrease the effective circulating volume. Okay. So let's go now to the hemodynamic changes in this five different types of shock. Okay. So here you have again the etiology of shock. You have the preload, contractility, and afterload. So for the preload, the problem is that there is a decrease in the intravascular volume. So you have now hypovolemic shock. So for example, when you have a hemorrhage, so because of the decreased intravascular volume, of course, it will decrease the venous return, and therefore your central venous pressure will be likewise be low. Okay, so decrease central venous pressure and right atrial pressure will decrease the stroke volume and therefore your cardiac output. And when you have a decrease in the cardiac output, there is a decrease in the arterial pressure. Okay, so as a compensatory response, you will have a decreased baroreceptor firing, which will increase the sympathetic outflow. So you have now sympathetic vasoconstriction. So you have now an increase in the systemic vascular resistance. Of course, since the cardiac output is low, you have a decrease in the oxygen saturation. Okay. Now for the second one, cardiogenic shock. So the problem is in contractility. So here you have a very low cardiac output because of decreased pumping capacity of the heart. Okay. So the CVP this time will be high. So remember in the vascular function curve, whenever you have a decrease in the cardiac output, the CVP will increase. Okay. So this will lead again to activation because of the decreased cardiac output, activation of the sympathetic response. So you have an increase in the systemic vascular resistance. Okay. So what about the afterload? So we go now to the three types of shock under afterload. So you have here the septic shock, neurogenic, and anaphylactic. So for both the neurogenic and anaphylactic shock, because of the vasodilation, there will be a decrease in the effective circulating volume. Okay, so the decrease in effective circulating volume, of course, will decrease the central venous pressure. So you have decreased venous return, and the decrease in venous return will, of course, decrease your cardiac output. Okay, so remember that there will be no compensatory sympathetic response in this case, mainly because the problem here is already vasodilation, so your systemic vascular resistance will remain as will also still be very low. Okay, so the same thing when you have a low cardiac output, of course there will be a decrease in oxygen saturation. Okay, now for septic shock, you have actually two types. So the first stage is the early stage. So in the early stage, it's a hyperdynamic septic shock. So as you can see, you can either have a low or high CVP, but the cardiac output would be very high. So this is because in the early stage of shock, there will be activation of the sympathetic nervous system, which will increase the heart rate and contractility, causing an increase in cardiac output. So the increase in cardiac output will increase the O2 sat. So of course, again, the problem is vasodilation. So you have a low systemic vascular resistance. Okay. Now, what about in the late stage? So in late stage, it's called hypodynamic because now this time the cardiac output will be decreased. Okay. So why is it decreased now, the cardiac output? Because the compensatory mechanisms will not be strong enough to keep the blood pressure up. Okay, so the tissue perfusion will still be inadequate. Okay, so this time you have now a low VO2. Okay, so this the systemic vascular resistance will actually increase because you will have selective vasoconstriction brought about by the sympathetic response. Okay, so the sympathetic response will only cause selective vasoconstriction. So release of catecholamines will only cause selective effective vasoconstriction, but it will not. It will fail to increase the cardiac output, and so your VO2 sat will still remain very low. So we answer now this question in septic shock. Which of the following is true? Okay, so the first option, decreased blood volume. So this is actually seen in cases wherein you have a hemorrhage, for example. So this will actually decrease the venous return and therefore decrease the preload. Okay, so the problem here is preload. So this is a hypovolemic shock. Okay, so for option C, decreased ejection fraction. So meaning there is decreased pumping ability of the heart, therefore decreasing the stroke volume. So this is inherent to the heart. So the problem is in the contractility. So this is a cardiogenic shock. Okay, so for the second option, generalized vasodilation and decreased venous return. Of course, in septic shock, actually you will have vasodilation brought about by the toxins that will cause the release of your nitric oxide, which will cause generalized vasodilation. And when you have vasodilation, of course, you will have a decrease in the venous return because of the decreased effective circulating volume, and decreasing the venous return will now result in a decrease in the cardiac output. Okay, so the correct answer here, of course, would be letter B. So generalized vasodilation and decreased venous return. So the first option is hemorrhagic shock. So this is hemorrhagic shock or hypovolemic shock. Letter C is a cardiogenic shock. Okay, so the correct answer here would be letter B. So that's the end of the presentation. Thank you very much for listening and for staying with me for such a very long review. But I hope you learned.
Okay, are there any questions? Wala naman. Wala akong marinig. Naka-mute kayo. Okay naman po. Naka-mute.
Ina-absorb pa
But
po, Doc.
ano yan? Okay naman?
Ina-absorb pa po.
Sobrang haba, no? So, it's really very comprehensive. Very, kasi hindi namin siya mapaiklian because there are so many concepts. So, we try to include as much as we can. But I think I hope it will help you reviewing for physiology. So, if you have any other questions, you just pwedeng mag-message na lang kayo. So, you have the chat option there. So, mag-message na lang kayo. For next week, it will be Dr. Solidum. So, Dr. Solidum, so same thing, question and answer format then, just like this one. And he will be discussing both the renal and GI physiology. So, I think there's only one round ng review for yung ACADS session, no? Kasi before 2 rounds yan. So, since one round lang siya, hindi na namin mako-cover yung ibang topics. So, we'll just, we'll try to give you some reading materials or handouts or PowerPoint presentation because aside from this, marami pa kaming mga presentation, no, covering cell physiology, mast cell integrative, and to cover. So probably we'll just send it through Anchi kung feasible. So if there are no questions, so I hope you review physiology again. Next week, it will be Dr. Solidum. So good luck. Kamusta naman kayo? So wala kayong hospital rotation, ano?
Wala pa po.
Ang hirap, ano? Parang puro ano na lang, imagination na lang, no? But anyway, hopefully by second sem, by January, pwede na kayo mag-rotate sa hospital. Okay? So again, good luck. Maraming salamat sa pagkinig, pag-listening for such a very long review. But I hope nakatulong naman siya. Nakatulong ba?
Yes po.
Thank you.
Oh,
Okay.
yes po.
Yes po.
Oh, sige. Okay. So you can have your lunch now. So again, good luck. See you next week. Bye! Thank you, Doc.
Thank you,
Thank you po,
Doc.
Doc.
Thank you, Doc. Thank you po, Doc.
Thank you, Doc. Thank you po.
Thank you po.
Doc.
Okay,
Hi,
bye.
Doc. Thank you.